you. Good morning, everyone. Welcome to the March 23rd Enforcement and Compounding Committee meeting. My name is Maria Serpa, chairperson of the committee. Before we convene, I'd like to remind everyone present that the board is a consumer protection agency charged with administering and enforcing pharmacy law. Where protection of the public is inconsistent with other interests sought to be promoted, the protection of the public shall be paramount. This meeting is being conducted in person and consistent with the provisions of Government Code 11133. Participants watching the webcast will only be able to observe the meeting. Anyone interested in participating in the meeting must either be here in person at the public location included on the agenda or join the WebEx meeting. Information and instructions are posted on our website. As I facilitate this meeting, I will announce when we are accepting public comment. I've advised the meeting moderator to allot 3 minutes to each individual providing comments. This approach is necessary to facilitate this meeting and ensure the committee has the opportunity to complete its necessary business. I would like to ask the staff moderating the meeting to provide a general instruction to members of the public participating via WebEx. Moderator?
Thank you, Madam Chair. Before we get started, I would like to remind board members and staff who are not speaking to mute their microphone during today's meeting. If background noise is detected as a result of unmuted microphones, I will mute those microphones. There are members of the public in the audience and meeting minutes are being taken, so we ask members and staff to please identify themselves before speaking. For purposes of today's meeting, when the chair opens public comment, members of the public who would like to provide public comment at our DCA headquarters location in Sacramento can approach the table and microphone at the front of the room. For those joining us on WebEx, we will be utilizing the WebEx question and answer and hand raise features to facilitate public comment. When public comment is called, I will open the question and answer feature, which you will hear me refer to as a Q&A, and members of the public who wish to make a comment can click on the Q&A icon, type the word comment in the text box, and click on the send button. To utilize the hand raise feature, simply click on the hand icon next to your name to raise and lower your hand. Those of you who have called into the meeting can dial *3 to raise and lower your hand. After we have taken public comment from our Sacramento locations, I will call on those individuals requesting to comment through WebEx. And with that, I return the floor back to you, Madam Chair.
Thank you. I'd like to now take a roll call to establish a quorum. Members, as I call your name, please unmute your microphones in front of you before speaking. Jig Patel.
Licensing member present.
Renee Barker.
Licensing member present.
Indira Cameron Banks is not going to be able to join us today. Sung Oh.
Licensing member present.
Ricardo Sanchez is not also able to join us. A quorum has been established. Members, as we begin today, I would like to thank you and all the members of the public for your time and participation today. I request everyone participating to be respectful of the work before the committee. We encourage participation by members of the public through our meeting at the appropriate times. The committee respectfully requests that when comments are provided, they are done so in a professional manner consistent with how the board conducts its business. As included in the agenda today, the committee will focus its efforts on Chapter 797, Pharmaceutical Compounding, Sterile Preparations, and discussion of the board's current regulations and evaluation on if any changes are appropriate to assure consumer protection. I will discuss this in more detail when we discuss agenda item 5. Let's start with item number 2, which is public comment for items not on the agenda. As we begin today, we will take public comment for items that are not on the agenda. I'd like to remind members of the public that you are not required to identify yourself, but may do so. I would also like to remind everyone that the committee cannot take action on these items except to decide whether to place them on a future agenda. Members, following public comment on this agenda item, I will ask you to comment on what, if any, should be placed on a future agenda. As a reminder, this agenda item is not intended to be a discussion, rather an opportunity for members of the committee and members of the public to request consideration of an item for future placement on an agenda, at which time discussion may occur. Moderator, we're ready for public comment.
Thank you, Madam Chair. I've opened up the Q&A panel. If any member of the public would like to make a comment, Please type comment using the field in the lower right-hand corner of the screen and submit it to all panelists. Just a reminder, please do not use the Q&A panel as a means to write out your question or ask questions of the committee members. You may also simply raise your hand if you'd like to make a public comment. And we are displaying instructions. Please remember you have a 3-minute time limit. I will give you a 10-second warning. And I do see we have a request from Dick Sullivan. Dick, you should be able to unmute yourself.
And also, meeting moderator, we do have public comment in the Sacramento location when convenient.
Oh, yes, I apologize. Let's go with the in-person comment first.
Thank you. I neglected to ask for the in-person comment first. We have someone coming to the table.
Good morning. My name is Marie Kottman. I own a compounding pharmacy down in Stockton, California, and I appreciate the opportunity to approach the board this morning. I am very clear that this is for a future agenda item and no discussion will happen this morning. You may know that some oncologist practices prepare and administer chemotherapy infusions at their practice sites. I am personally aware that sometimes pharmacy technicians are employed to prepare these chemos without the supervision of a pharmacist. In an effort to assist the board in being proactive rather than reactive, I request that you consider at a minimum to discuss this issue at a future board meeting. I am concerned that the cancer patients may be receiving substandard compounded pharmaceuticals that are not prepared to the standard of practice that we in pharmacy have come to anticipate. If harm were to come to any one of those patients from the lack of facility controls, lack of adequate and appropriate employee training, or lack of oversight of the compounding process, the entire practice of pharmaceutical compounding would be scarred. It seems prudent for the Board of Pharmacy to somehow regulate the practice of its technician licensees who are not being supervised by a pharmacist with the purpose of both preventing and avoiding patient harm. If you question whether this is in your purview, you need look no further than the About page on the Board of Pharmacy website. There you will see that part of the purpose of the board is to, quote, serve the public by advocating the highest quality of affordable pharmaceutical care, and that the board regulates, quote, pharmacy practice of pharmacists, interns, and technicians. And further, quote, the board also regulates all types of firms that distribute prescription drugs and devices in California. If this page is accurate, the practice of compounding prescription chemos in an oncologist's office would be well within your scope. Thank you for your time. I hope you will consider this matter.
Thank you. There is no more public comment here on site, so we're ready for the WebEx.
Thank you, Madam Chair. All right, Dick Sullivan, you did have your hand raised, so you should be able to unmute yourself if you have a comment for this agenda item.
Thank you.
And you're, Okay, our next request, so apparently he did not have a comment. Our next request for comment is RX123, and give me a moment and I will let you unmute yourself. All right, RX123, you should be able to unmute yourself. There you go. You're unmuted.
Thank you so much. I have an anonymous question. So we have heard of Board of Pharmacy inspectors who may have asked other sites to perform a repeater pump media fill test to serve as the media fill competency for employees. And so can the board please comment and consider commenting on why performing a repeater pump media fill test is considered a more complex aseptic manipulation for employees versus performing 20 manual aseptic transfers from a TSB vial into a TSB bag. And respectfully, I thought that each facility can determine the media fill test based on their most complicated preparation. Thank you for your time.
Thank you.
All right, this is the moderator. I see no further requests for public comment. Should I close the Q&A panel?
Please do. Thank you.
You're welcome.
Members, we have received public comment, and looking at two items that were discussed, I believe the first one, before I ask if we have any determination, I believe the first item is on the licensing committee agenda. We've talked about that in the past, about where technicians practice and the practice of compounding in different sites. Ann is shaking her head yes, that it is on the agenda for the licensing committee. So members, would you like to include this item or any other items that were discussed in the public comment on a future agenda?
If the role of technician is definitely on licensing committee agenda, then there would be redundancy to add to
Right.
our agenda, so.
Great.
But it should be on one or the other.
Right. Thank you. Okay, agenda item 3, approval of the February 15th, 2023 committee meeting minutes. Members, included in attachment 1 of the meeting materials are the draft minutes from the committee's February 15th meeting. Members, do you have any questions or comments on the draft minutes? As a part of your comments, I will also entertain a motion.
Chair Sharp, I'm happy to make a motion to approve.
Thank you. Dr. O, do I have a second?
This is Jig, I'll second it.
Jig seconds, thank you. With a motion and a second on the floor, I'll now open the discussion for public comment. Moderator, please, let's start in person. Are there any comments on the meeting minutes? No in-person comments? Moderator, we're ready for WebEx comments.
Thank you, Madam Chair. I've opened up the Q&A panel. If any member of the public would like to comment on agenda item, the meeting minutes, please type comment using the field in the lower right-hand corner of the screen or simply raise your hand. We are displaying instructions and we'll give you a moment. All right, I see no requests for comment. Shall I close the Q&A panel?
Please do, thank you.
You're welcome.
With a motion and second and public comments received, I'll now take a roll call vote. Jig Patel.
Yes.
Renee Barker. Yes. I don't know if your microphone's on. Yes, there you go. Sung Oh.
Yes.
And the chair votes yes. Motion passes. Item 4 is presentation on the USP General Chapter 797 regarding pharmaceutical compounding sterile preparations. Before we begin our discussion today on possible changes to the board's current regulations on sterile compounded preparations, we will receive a presentation from Supervising Inspector Christina Costa on the revised USP Chapter 797, which is related to pharmaceutical compounding of sterile preparations. The provisions of the chapter become effective on November 1st, 2023. Attachment 2 of the meeting materials include the presentation slides and a copy of the USP 797 FAQs dated from November 1st, 2022. I would encourage all stakeholders to monitor the USP website for updates on its FAQ. Welcome, Dr. Acosta, and we're ready for your presentation.
Wonderful. Good morning.
Can we hear her?
I'm sorry, what? Oh my, you can't hear me. Okay, next slide, please. We're going to go very, very briefly over USP. 797 chapter, the education offered by USP was an 8-hour course. When we trained staff, we did an 8-hour course and then 2 6-hour courses. So please understand what we're providing today is an extreme overview, and the slides are pretty deep. We're not going to go into depth in them. It's to give the committee members just a general sense of what we're going to talk about when we look at the regulations we're proposing. So, oh yes, of course, no disclaimers. Some of the things I may say were just my opinions. Next slide, please. All right, so like all the other chapters we've talked about, USP 797 is broken into specific sections. Next slide. And you'll see that there are 20 distinct sections. In this chapter, you'll see that this is very parallel to the regulations that we are going to talk about next. Next slide, please. All right, so let's talk about the first section. The first section in almost all the USP chapters is introduction and scope. And so what you need to understand in 797 is these are minimum practice standards. They're not meant to be the top floor. They're meant to be the entry lower level floor. They're related to all persons and all locations that compound sterile preparations. Next slide. All right, so compounding in 797 has a slightly different definition than it did in 795, and you'll see that highlighted here specifically is repackaging. So it's important to note when we talk about the word compounding and you're talking about a sterile product, it's going to include combining, admixing, diluting, pooling, reconstituting, repackaging, and otherwise altering a drug, bulk drug substance to create a sterile preparation. So whenever you talk about anything, please make sure that we're talking about it within the scope of compounding, because there are several things that do fall outside the chapter, such as administration. So administration has always been outside USP 797. Again, it still is. A change we're going to see is how the proprietary bag systems are used, and what the proprietary bag systems are is they're the vial and the bag systems that actually connect them together. It will not be considered compounding when it is done for an individual patient for immediate administration. So normally this is used when a nurse connects the two, immediately uses it on individual patient. That is not compounding. However, it will now be compounding if it is docked or put together for future use. So keep that in mind. That will be considered compounding, and all the requirements of USP, except for the beyond use date, will be a requirement for those docking for future use proprietary bag and vial systems. Next slide, please. All right, so we could probably have an hour conversation on immediate use. I'll try to do a brief overview. So immediate use, everybody's excited about the beyond use date that we're gonna be able to use under 797, which is basically 4 hours from a 1 hour. But you have to remember there are requirements in order to be able to use it as an immediate use provision. The chapter outlines seven of them, and we've listed them in the slides for review. The most important thing, besides the BUD and the immediate use, is instead of it being actual sterile products, so the number of vials, the number of bags, it's actually the number of products, rather. So it's a bag is one, a diluent is one, and then you could have, like, so CryoFab, right? Sometimes you need 5, 10 vials. That was always an issue for an immediate use preparation because that would exceed the scope of what it currently is allowed. So that won't be a problem for immediate use anymore, because it's really by the type of product, not necessarily the number of vials or containers that are used. Also, it needs to be for direct administration, and there are some labeling requirements, but most of the time, in my experience, immediate use is going to be immediately administered, so the labeling requirements are going to be at minimum. Next slide, please. Okay, here's where the chapter deviates a lot. So we are very used to, for the last way too many years, we've been using low, medium, and high risk as terms. So we are transitioning into something called categories. So we're going to have a category 1, a category 2, and a category 3. And those are more based on the environment in which the product is compounded versus the products that are used to compound it. So was it in a clean room suite, which is a buffer room and an anteroom? Was it made in a compounding segregated area? That depends on what category of CSP will be made. So I just mentioned clean room suite. The definition of that is going to be a classified area that consists of both an anteroom and a buffer room. It's surprising, but just very clearly, all the categories, so category 1, category 2, or category 3, you can use any type of starting ingredient, sterile or non-sterile. This is a big difference from what we saw in the low-risk category, where it's only allowed to be sterile to sterile. So you can now, well, on 11.1, and when our regulations change, you will be able to do non-sterile to sterile compounding in a segregated sterile compounding area. So again, when 11.1 comes around and we change our regs, then that would be an acceptable practice under the USP chapter. Next slide, please. All right, so we talked about this briefly. So category 1, or throughout the slides, I'll talk about it as Cat 1. So this is the segregated compounding area, the primary engineering controller, the PEC. And this is a change from that SCA category that we had before, where we do low risk, and it was always 12 hours or less. There is now going to be an allowance for 12 hours or less, or 24 hours or less if it is refrigerated. So again, that will be a practice change. And then there is category 2. And I like to think of category 2 as kind of like the in-between, because there are a lot of things that fall into category 2, but the one thing that always remains the same, that it's a primary and engineering control in a clean room suite. So that is a full clean room. And we'll go into very briefly some of the BUDs that are allowed, but they are all greater than 12 hours. Next slide, please. Category 3. So when the chapter was remanded last time, this is one of the major changes that was added to USP, was the addition of this category 3. So this category 3 is, in my opinion, kind of the transition into where we would get close to a pharmacy practicing under CGMP, but not really there. There are higher garbing and gowning and cleaning and all these other requirements, but you are also allowed to get a much longer BUD. So we have category 1, category 2, and category 3. Next slide, please. All right, so training and evaluation. There are a lot of very detailed things in here, but what you need to understand is that the chapter now talks about those who are compounding and those who have direct oversight of those that are compounding. And when we talk about training and evaluation, both of those types of participants are going to have different types of training. There's written programs that describe all of the things. It's very detailed, and for the sake of time to get to our fun work today, we're going to skip a lot of the details. It's here, it's in the chapter. I highly encourage you to read this section 2 and 3 times and get the depth of what this means for your facility or your practice. Thank you. Next slide. All right. So we are going to get this new term, demonstrated knowledge and competency of core skills. And this is going to happen a minimum every 12 months. And you can see there's a whole list of things that the staff is going to need to be trained in. Again, that's not only the compounding staff, it's going to be those with oversight. So there's going to be different requirements as far as frequency about what you're actually doing, but actually what they need to know is going to be very there. The chapter directly addresses what if there's only one person that compounds, and we do have some compounders that are very small. So please, if that is you, go ahead and look at the chapter specifically about what your requirements will be. Next slide, please. All right, we're all familiar with gloved fingertip and thumb sampling, and it now says thumb. It used to just say gloved fingertip, but apparently your thumb is a different digit now. All right, so it's gonna, originally it's going to talk about your ability to put on your garb sterilely. So originally or initially when you are compounding, you're gonna have to be able to completely garb and do 3 of these glove fingertip and thumb samplings with 0 CFUs, meaning you are able to put your garb on without contaminating your gloves. We have to do that 3 times initially, and that's going to be before you're allowed to do any compounding independently. And then as a ongoing basis, it's going to be the same standard that we have now. It's really greater than 1 from both hands. But what you're going to see is when we're going to actually do this as part of ongoing competency. Next slide. All right, so ongoing training and competency. We are actually going to have for that category 1 and category 2 compounding products. So your training is based on the type of room that you have and the type of product that you're compounding, right? So we talked about category 1, category 2, and category 3. So if you're going to do that category 3, the higher end, longer BUDs, you're going to have higher competency training and room requirements. You're going to see that throughout the chapter. And then again, you're going to see a different section that for the people with direct oversight, which is a little bit less. So here you'll see for category 1, category 2, we're going to do it every 6 months. But what's really important here is you are going to do your glove fingertip test after completing the media fill. So you're actually going to manipulate something and then see how contaminated your hands got, and that's actually going to give us a better idea of your actual compounding process and techniques. So category 3, you're going to do it every 3 months, and if you're just doing direct oversight, you can do it every 12 months. But I do caution, if you're just doing direct oversight and you're only doing it every 12 months, that does mean that you are not competent to go in and compound. So if you have staff that maybe doesn't regularly compound, but in an emergency they would have to, I would highly encourage you to just test them every 6 months just so you have them trained, because this will take a little while, up to 14 days for them to be trained. If you're in an emergency and you need a staff to compound, we need to prepare for those instead of react to them. Next slide, please. All right, so this is just an example of some glove fingertip and thumb sampling. We see people use the paddle, which is the purple gloves one, and then an actual Petri dish where you stick your fingers in it on the white gloves. Next slide, please. All right, so media fill test, what is this? So overall, it just is a test to see if the compounder can safely aseptically process, so without contaminating a product, and it's supposed to simulate the hardest, most grueling tasks that they would do. And the idea is that the facility needs to pretty much outline and do this, and it's going to be, again, on an ongoing basis, and this is going to happen before we do our glove fingertip test. Next slide, please. All right, so these are just some examples that I pulled on what may be a media fill test, and what you can see is it just really depends on what the most complicated thing you are doing is. So if I'm just doing simple transfers where I make multiple diluted products and then I make them into one pooled vial, that would be that first picture where I have 4 different vials of different drugs and maybe the end product has 4 different drugs in it. So I would need to go ahead and process that, and then I would need to incubate that final vial, which simulates the patient's received vial, to see if I made that safely. You would also have to do this if you were doing non-sterile to sterile. You would have to start with a non-sterile process. And in the chapter, it actually talks about when you do a media fill from non-sterile, you actually have to make a positive control. You have to make a contaminated vial to ensure that that contaminated vial actually grows something, or else your process is not validated. So it's very interesting. Each of these is going to have to be specific by the practice. So next slide, please. All right, aseptic manipulation. So this is a broad term for visual observation. So yes, somebody actually has to watch what you're doing. The media fill test that we just talked about, followed by the glove fingertip test on both hands, and surface sampling. So now we have this whole plethora of testing all at one point in time. So what's going to happen is you're going to have to pass this test initially before you're allowed to compound independently, and then ongoing, you'll see that Cat 1 and Cat 2 is every 6 months, 3 months for the Category 3, and 12 months. So this is going to be one set training session where somebody will watch you compound, they'll watch you do your media fill, you'll do your glove fingertip test, and then you'll do a surface sampling to see if you contaminated your environment as well. It's going to be a really nice snapshot of the overall aseptic manipulation that compounder is doing. Next slide, please. All right, personal preparation. Not a huge difference from where we are on this. I would say that they did clarify that eyelashes, that was a big thing last time, they are considered cosmetics and they will no longer be allowed in the clean room. And then there's a request to wipe the eyeglasses, because we were finding that eyeglasses were not being cleaned. Next slide, please. Hand hygiene. Not a huge difference again in this one. Hand hygiene has been pretty standard. There is a disallowment now for brushes, a disallowment for any type of air dryer to be used as well. And you will see that the persistent activity alcohol-based hand sanitizer has left. We do not require, they will not be required to have persistent activity anymore. Next slide, please. All right, so garbing. This is going to be broken down specifically into what category you are compounding. So if you're going to do Category 1 and Category 2, you must have the same low lint garment with sleeves that fit snugly around the wrist. It may be reused for the entire shift. You are going to have shoe covers. You're going to have to cover your head, a low lint face mask, and sterile gloves. There is a comment about the RABs, which it's a new term. We're going to use RABs, which is a CAI or a CACI. The sterile gloves must be worn over the gloves attached to the RAB sleeves. Next slide, please. All right. So this is a continuation for Category 1 and 2. You are not allowed any exposed skin in the buffer room, so your face, excuse me. This is Category 3, which is additive to the 1 and 2. So this is where we get into the CGMP-esque. So you are going to be in No, nothing is showing, not your forehead, not your neck, not your face, nothing. Low lint outer garment must be sterile. So not only are you going to be garbed, but it's going to be sterile garb. Keep in mind, it is not easy to put on sterile stuff without hitting the floor if you're putting on booties and things like that. So this is a competency that is not easy to pass. There is a process of putting on sterile garb that most pharmacies are going to have to work through if they want to do Category 3. So disposable garbs must never be reused. So unlike with the Category 1 and 2, you can reuse your gown. Category 3 will not be reusable. If you choose to use laundered garb, it must not be reused without going through a validated cycle. And your SOPs must describe disinfection procedures for all reusable equipment, such as goggles or something to that effect. Next slide, please. All right, so here's the difference. I tried to find a picture that would help you understand the difference. Normally, good gowning for Category 1 and 2 is going to be the person, not sure the gender, sorry, and the bouffant cap. That's normally what we would see in our sterile compounding for 1 and 2. And then when we see a facility that will be compounding that Category 3, they will be expected to be garbed in a full sterile garb, head to toe. It's a big difference in garbing, and it will be a big difference in practice if they choose to stay with the Category 3. Next slide, please. All right, facility design. Not a huge difference. I mean, it's always been an ante-room is ISO 8 to a positive pressure buffer room. If it's negative pressure, it has to be an ISO 7, and that again makes sense because we want really clean air to go into a negative pressure room versus the positive pressure will pull the 7 air into the 8. All buffer rooms are going to be required to be ISO 7. And then here's a little bit different. So temperature, humidity monitoring will be required each day, but the chapter does specify each day when compounding takes place. So that does help a little bit. We have had lots of conversations about what do you mean have to go in and clean or have to monitor something on days when that facility is not even used. The chapter is very clear on the fact that it's when compounding takes place. Next, please. All right. I am not even going to remotely go into all of this, but these are all of the requirements for a clean room suite. And again, a clean room suite is required for Category 2 and Category 3, and a clean room suite will always have an ante and a buffer room. Okay, so the key here is fixed walls and doors. That is something very different than we have seen. So they must be fixed. They can't be movable. So we used to see, we call them meat curtains. Those are no longer going to qualify as a clean room because it has to be fixed walls and doors. So there's a ton in here. If we have questions, committee, we can go over some of that, but I'm going to go ahead and go to the next slide for time's sake. All right, so here is a design that we do see. I actually just took this from the advisory guide that we made with OSHPD last time we were going through regs, just to give you a general sense of, so the errors or the pressure differentials, well, you'll see the non-HD, the pressure differential will go from the ISO 7, it'll go into the anteroom. But then when you see the HD, when you open that door, the air is actually going to influx in, which keeps the HD into the HD externally vented room. And then you'll have a clean room or an anteroom that has a clean side and a dirty side. And in this case, the sink is actually on the dirty side. That's one of the things in garbing in the new chapter, that the garbing order really depends on where your sink is. So this is just a general sense of some of the pharmacy designs that we see. We see all kinds of different ones. So while we talk about the requirements, it's hard to say some of the very detailed aspects of what would be allowed and what wouldn't be allowed until we see the full picture of how they're designing things. Because we are now seeing an anteroom with a non-HD buffer room with an HD buffer room off the non-HD buffer room. So then this whole schematic would be kind of turned on its head. So next slide, please. All right, so here's a visual of what a buffer room may look like. And again, you'll see carts and you'll see people properly garbed. Clearly in this picture, they would only be able to be making Category 2, and I say 2 and not 1 because this is likely a buffer room and not SCA, but it could be, so they could be making Category 1. Next slide. All right, so compounding or segregated compounding area, an SCA. It must be located away from unsealed windows, doors that connect to the outside and traffic flow. and all environmental challenges. The sink must be at least 1 meter from the PEC. Next slide. So this is, again, just a diagram from the OSHPD guide, which I know they're not called OSHPD anymore. I can't think of HCI. Haha, HCI, their former document with us. And so it just gives you a general sense of what we normally see is a PEC in corner against a wall, and there's a hand washing sink, and there's some type of rack, but then there's an area for donning and doffing gown. It's just a little bit different of a schematic than what you would see if you had a clean room suite. Next slide, please. All right. Where to start on these? So we used to use a CAI and a CACI as a complete containment for compounding, and they used to be allowed to be placed in a non-controlled environment, such as a SCA. When the new chapter comes in, that will no longer grant you longer BUDs. A RABS is going to be treated as any other PEC, so it will not grant you a longer BUD. What that means is if you built a segregated compounding area and you have a RABS, you will then be compounding only Category 1. And you will be only granted the BUD for Category 1, so that's 12 or 24 hours refrigerated. That's going to be a significant change for some of our acute care facilities in the state, but it's very important to know that that's where USP is going. If they want to use a RABS and they want to put it in a clean room suite, absolutely acceptable, like any other PEC, then you can do Category 1 or Category 2 with it. But this is a significant change from where we were. I have never seen any pharmacy with a pharmaceutical isolator. So there is a big difference between an actual pharmaceutical isolator and a RABS. Next slide, please. This is a RABS. This is normally what we see. And depending on whether it's negative pressure or positive pressure, it would either be containment or not. Next slide, please. This is a pharmaceutical isolator. Yeah, we don't see these in hospitals. We don't see them in pharmacies because generally they are very, very expensive. So there is a big difference between the two. If somebody has a pharmaceutical isolator, there is a lot of things they can do with it, but it's not really in the practices that we see. Next slide, please. All right, so we talk about the environments, and so then we have to talk about the purging or the movement of air. So air exchange per hour requirements. In the SCA, there is no requirement because it's considered uncontrolled air. ISO Class 7, you must have 30 air changes per hour. At least 15 of those air changes per hour must come from your HVAC, so your heating, ventilation, air conditioning thing. So it must come in through the vents and go out through the vents. It can't just be recirculated air. And the ISO Class 8, it must be greater than 20, at least 15 from the HVAC system. And I highlighted that because we do have locations in the state of California where they do meet ISO 8, which is just a particulate count in the air, but they do not have HEPA filtered air inlets, and they don't have any oh my goodness, what's the low air returns? Thank you. My brain's slow. So it is very important that the requirements of the chapter are going to require 15 of those air changes per hour to come from an actual mechanical ventilation system. So it's also important to know if the primary engineering control is used for any of the air changes per hour, it must never be turned off. So you're allowed to use it for some of those air changes per hour, but if you do, you can never turn it off. And I know that some of the facilities wish to turn it off because it is a cost-saving mechanism when they're not using it for 24, 48 hours. So you need to make sure when your certifier comes in that that certifier can identify if you can turn that off or on. Next slide, please. All right. So Category 2 and Category 3 from non-sterile components. You will note that Category 1 can be made with non-sterile, but it is not part of this section. This is only Category 2 and Category 3 from non-sterile. So any and all pre-sterilization procedures, weighing, mixing, must be completed in an ISO Class 8 or better environment, and it must be in a single-use containment glove bag, a containment ventilated enclosure, a biological safety cabinet, or a CACI. That last requirement is new. It's always been required to be in an ISO 8, but the requirement for it to be in some type of closure is new. Next slide, please. All right. There is a lot on certification and recertification. So the bottom line is it's going to still be every 6 months. We absolutely are going to test the airflow velocity, the air exchange, and the room pressure differentials. All HEPA filters must be checked for integrity. You must do your total particulate count and dynamic airflow pattern test for each primary engineering control. You must define what your dynamic operating status is. So dynamic means under normal operating procedures. So if you have 1 4-foot hood, your dynamic operating procedure is probably 1 person compounding in there at a time. But if you have 6 8-foot hoods, I mean, you could have 10 people in there at a time, and that's the dynamic state in which your room should be certified, because even though you may meet particulate count at static or at rest, the number of people and the number of movements in the room will bring that count of particles up, just because people shed, items shed, and then that air change per hour will actually have to be much higher to keep the particulate down. The more you move the air, the cleaner the air becomes. So sometimes what happens is everybody does really great on that initial test when they get a new clean room, then they start using it and they realize they will never meet the ISO 7 that they need the room because they didn't do dynamic testing. So it's very important to understand that this is going to be a dynamic testing situation at all times. Next slide, please. Oh, surface and air sampling. You must do your air sampling by volumetric, meaning you draw in a certain volume of air, 1 liter, to a device that holds the Petri dish. This is very different than a settling plate. Settling plates are not going to be allowed. So again, category 1, category 2, we're going to do it every 6 months. So category 3, 30 days before the start and monthly. And surface monitoring is initially and monthly, so that's different. We're going to be doing a lot more surface sampling. 1 and 2, it's going to be monthly. And category 3, you are going to do it initially, weekly, and in the PEC at the end of every single batch. So if you've chosen to do category 3, every single batch of drug that you make, you will take a surface sample at the end of that batch. That's a dramatic difference than the 6-month point in time that we were getting before. So we'll have a lot of data on microbial growth. Next slide, please. All right, so again, all classified areas, you need to do new facilities, you need to have a response if there is a problem. There is a lot of requirement for your SOPs to define what you are going to do if there is a problem. It's extremely important for you to think through all the possible problems and come up with a plan before the problem arises. And again, all the microbial air and surface is going to be under dynamic operating. It doesn't help to have nobody in the room but the person testing the surface sample when normally you have 25 people in the room. We want to know actually how your products are made. Next slide, please. All right, so here's our action levels. So air, if you're in your ISO 5 environment, you have greater than 1, meaning 1 would be acceptable. Surface, you have greater than 3, meaning that 1 and 2 and 3 are acceptable. So if you go higher than that, you need to have an action level. So keep in mind what that means is that surface sample that I am doing at every single batch, and I do category 3, that surface after compounding has to have 3 or less at all times. So it's very important that we're going to get a lot of good feedback on technique and cleaning as things go into the PEC, as they go into the buffer room. We're going to get a lot of feedback on that. So 7 is going to be 10s and 5s, and 8 is going to be 150. Here's the other wonderful thing that we got. It actually must be incubated. You must have an incubator. It must not be located in the sterile compounding area, and you actually have to incubate your samples. Even though the media may grow in a range that is room temperature, you need to have controlled room temperature in incubators. So it's very important that pharmacies will need to be able to incubate. Next slide, please. All right. So I don't even know where to start on this. So there is a nice table, Table 10. I would encourage all of you to actually digest it and read through. This is just a snippet of what it says. So the sporicidal changes slightly for the category you're making. Everything else is very similar. Next slide. This could take me 3 hours to go over, so go ahead and dissect that a little bit. There is a nice section in section 8 in the chapter now where it talks about taking things from one area of cleanliness or classification and moving it to the next, and the things you need to think about. So wiping it with a sporicidal, disinfectant, sterile IPA, and actually talks about wiping it instead of spraying it. It's very important that we actually wipe the mechanical nature of actually wiping something as part of the cleaning process as well. When you move it into the PEC, you must wipe with sterile IPA using a low lint wiper and allow it time to dry. IPA is the best when it slowly evaporates and denatures things. So the critical site or the top of the vial, those types of things must be wiped with sterile IPA and allowed to dry, which means there's going to be a little bit of delay between the time you get your vials in there, you wipe them, let them dry. In the ISO 5 environment, they should dry pretty rapidly with that airflow, but you have to let them dry. It doesn't do any good to puncture before it's dried because we haven't eliminated any of the contaminant. Next slide, please. All right, equipment. Your SOPs, again, back to the SOPs, and your pharmacy must decide how exactly you are going to do processes. Calibration, maintenance, cleaning must be based on the manufacturer's recommendation. So if you buy a piece of equipment, one, make sure that it's appropriate for the use that you plan to use it for, and then look at how often it needs to be calibrated, cleaned, parts replaced. It's very important that we use equipment that is in good condition in order to have the accuracy of it. You must maintain daily records of the accuracy of measurements on the days the equipment is used. So TPN compounder must be calibrated each and every day that you plan to use it. You must maintain that record. Supplies in direct contact with the CSP must be sterile and depyrogenated. So keep that in mind. Next slide, please. Component selection. Conventionally manufactured sterile products should be used when available and appropriate. So the chapter uses this as a shall. Each component must be evaluated for suitability for the use in the drug preparation. That is a must, it is a requirement. Components labeled with not for pharmaceutical use, not for injectable use, not for human use, or equivalent statement must not be used as components for these purposes. It's very important when we get our components that we look and see what they're labeled as. What does the certificate of analysis say? What is any of the shipping documents that you got? What does the box say? What does the packaging say? Look at your products very carefully. So now if we just look at one type of component, which is the active pharmaceutical ingredient. So that is the product that we put in our CSP to actually have an effect. They must comply with the criteria in a USP/NF monograph if one exists, must have a certificate of analysis, must be manufactured by an FDA registered facility. Those are requirements for an API. Next slide, please. Okay, components other than an API. So this would be some kind of excipient. So it's not expected to cause a pharmacological effect, but it is going to act on some manner. Maybe it's a preservative or something like that in the drug. So it must comply with the monograph if one exists. It must have a C of A, should be manufactured by an FDA facility. When CSPs are used, they are the correct identity, appropriate quality, within the expiry, have been stored under appropriate conditions. So it's really important that you know where you are getting your products and where you are storing them. Some of these products are in powder form, so the dryness or the humidity can affect a lot of their properties, whether it be an API or not. It's very important that you know where they have been stored and that they have been stored properly, including shipping and manipulation at either a repackager or a wholesale location. So handling and storage in a manner that prevents contamination, i.e. we don't store anything on the floor. We don't store it next to an area that it could be drafted or it gets too hot or possibly some kind of vermin mix-up. So if you have two bottles that look similar, let's not store them together, or deterioration. Must monitor temperatures where components are stored at least once a day. So this is a new requirement. If you have a storage area where components are, we are going to be asking about the temperature at least daily in there. Next, please. Terminal sterilization. So I'm not going to go too much into the sterilization except for to say there is a distinct difference between terminal sterilization, where the CSP is already in its final container closure, and then it is sterilized. It's either dry heat, it's either steam autoclaving, or it is irradiation, which is extremely different than aseptic preparation, and that includes sterilization by filtration, right? So there are a lot of reasons why you would pick a certain type, but we need to differentiate terminal sterilization and aseptic preparation, because when we get to BUDs, they will become important. Next slide, please. Okay, so I'm going to kind of go over these really briefly. So dry heat depyrogenation, there is amazing resources on this. If you are choosing to do this in your pharmacy, please, please, please dive into USP, read the chapters in it, make sure that you understand the pitfalls and what you need to do. Next slide, please. Same thing here. This is a majority of what we see people doing non-sterile to sterile. So keep in mind your filters must be sterile. They must be depyrogenated. They must have a nominal pore size of 0.22 and be appropriate for pharmaceutical use. It is very important that when you are trying to sterilize a pharmaceutical, the filter you are using is meant to be used for that. The filter must be chemically and physically compatible with the ingredient. They must be stable at the pressure and temperatures for which they'd be used, and have enough capacity to filter the required volume. Next slide, please. Steam. So steam heat, that is just like the depyrogenation. If you're going to do that, and that is the appropriate way to sterilize your product, please make sure you've looked at the chapter, look at the validations that are required, and make sure that you're following them, because this could be extremely dangerous if you do not do it correctly. Next slide. Same thing with dry heat. I'm not going to go too much into it because we don't see a whole lot of it, but I highly encourage anybody that chooses this as the sterilization method that you really truly understand that it's appropriate and that you're doing it appropriate for the product that you're using. Next slide. All right, so master formula record, or you're going to see MFR. That's going to be a new acronym because we don't have enough. And in a chapter, an MFR is required in a batch that is for more than one patient, meaning you don't need an MFR if it's for only one patient. CSP is prepared from any non-sterile ingredient. So that's when it is going to be required in the chapter. The list is below, and it is in box 9 in the chapter. Next slide. All right, so compounding record, or CR, it is required for all CSPs with the exception of immediate use for one patient, and it may be in the form of a prescription, a medication order, a compounding log, or a label. And it may also be stored electronically, but must be retrievable. Next slide. Here are the requirements for the compounding log. They are in box 10 of the chapter. Next slide, please. All right, visual inspection. So this is something that is not new in the world of CGMP. It is a little bit new in the world of pharmacy as being required. It basically means you are looking at that product prior to dispense. You are looking at that product to make sure that there are no physical problems. So the chapter is going to require it to be before release, so at the end of compounding, at every single dispense. The idea is that in our world, the pharmacist knows that that product didn't have visible particulates, didn't have color leaks, we don't have coring, and it's going to happen not only when you verify the final prep from compounding, but every single time that it is going to be dispensed. very important that a pharmacist can physically put their hands on a product to know if it's leaking, to know if there's a problem, to pick up a bag and see if there's particulate that moves. It's going to be very important, and I think that this is going to be a very interesting practice change based on how compounding verification has evolved over the years. They also need to verify the label and the prescription match. The container closure has integrity. All of those things are going to be something that a pharmacist is going to have to do before release of the batch and dispensing. And any defect that is found is going to need to be investigated. Next slide, please. Sterility testing. This is where Category 2 gets a little bit muddy, and where Category 2 really becomes a transition place between Category 1 and Category 3. So in my bucket brain, I have a Category 2 and a Category 2.2 or 2.5, right? Because there are Category 2 preparations that are made, but they don't require a sterility test to get a BUD, or you've chosen not to do a sterility test, and that's acceptable. When we go into the BUD, you'll see how it's stratified out. So if the Category 2 that you are compounding requires a sterility test, the chapter breaks down the difference between using just purely USP 71, which is what we use to know how many articles or what volume we need to test in order to have sterility assurance for that batch. It actually breaks it down and it gives a little bit of leeway when you are making less than 40 CSPs. So the chapter breaks down how many units you have to test out of that batch in a Category 2, in all Category 3s, if you're doing a sterility test in that Category 2. All right? If you're going to do sterility testing, you must have a method suitability test. If you're going to use an alternative microbial method, then you must have it validated under Chapter 1223. It must show that it is non-inferior to the 71 test. If you have a failure, it must be promptly investigated. Next slide, please. Endotoxins, my favorite subject. All right. Only injectable products need to have this looked at. An endotoxin is not something of grave concern for certain other preps because endotoxins are the biggest problem in the bloodstream. So it must be compliant with Chapter 85 limits, and that is a calculation that each compounder needs to do based on the route of administration of their product. It is required for all Category 2 that start from non-sterile components and assigned a BUD that requires sterility testing. So here's where Category 2 gets super muddy. If you decide to make Category 2 and you decide not to do sterility testing, you don't have to do endotoxin testing either, but you get a lower BUD. But if you choose to do sterility testing, you have to do endotoxin testing if it's from non-sterile and you want to give the longer BUD. So it's really a differentiation. That's why it's kind of 2.5. So the ones that have the longer BUD that require sterility also require endotoxin testing. And Category 3, anything from non-sterile origins. Next slide. All right. The labeling, the most important thing here is, like you've heard from the other chapters, the difference between the label, which is on the actual immediate container, and the labeling, which is the new thing that's anything else that goes with the drug. So nothing too exciting here, that nothing changes necessarily from where we are with practice. Next slide. All right, everybody breathe, here we go. All right, the beyond use date hasn't changed. The beyond use date ends at the time the administration begins. That's how it's been forever. It's based on the factors that affect and achieve and the maintenance of sterility. The beyond use date in 797, as it has always been, does not take into account a drug that is not stable at the conditions for the amount of time that the allowable BUDs are. So keep in mind, we are only talking about sterility when we talk about 797. Okay, so next slide, please. All right. So beyond use date, terminal sterilization is always going to get a longer beyond use date than aseptic processing, which includes filter sterilization. Conventionally manufactured sterile preps are going to get a longer beyond use date than one or more non-sterile starting components. sterility test results within acceptable limits, we'll get a longer BUD than non-sterility tested products. If it's stored in the freezer, you get a longer BUD than the refrigerator, but the refrigerator gets a longer BUD than the room temperature. So I just tried to break down like how the BUD is in conceptual means. So when you assign a BUD, you must not exceed the shortest remaining expiration date of any starting component. Oops, forgot a word. CSP prepared from one or more compounded components, the BUD generally not exceed the shortest BUD for an individual compounding component. So there is a decent amount of conversation about the BUD once something is used or spiked, or the in-use time, or whatever term you want to use, versus the actual final BUD. I think that's slightly beyond what I'm going to be able to provide today, but it is very important for all our licensees to understand the difference in that and the assignment of BUD. So next slide, please. All right, so BUD for Category 1. So this is, again, Category 1 is the ones made in the SCA. Again, you can make any non-sterile or sterile prep in here that you want. So you can have a less than or equal 12 hours if it's controlled room temperature refrigerator. You can have the 24 hours. Again, the note, shorter BUD must be assigned if the physical and chemical stability of the CSP is less than the BUD stated in the table. So it's very important to understand we're only talking about sterility with the table. Next slide, please. Okay, here we go. Okay, so this table is very busy, but very easy to understand once you get the concepts that we've been talking about for, I don't know, the last half hour or so. Okay, so if you look, the first column, compounding method, aseptically processed or terminally sterilized CSP. I would say most of our practices are going to be in this first part. Aseptically processed will mean sterile to sterile, and it's also going to mean anything that is filter sterilized. And remember, we're in Category 2, so we are already in a clean room, right? So aseptically processed CSPs. Then the second column is sterility test performed and passed. It doesn't mean it's pending, it has passed, right? No, okay, yes, okay, then we go to the next. Then the third column is going to be the storage requirements, and the first section is that it's going to be controlled room temperature, right? And then this is where it gets a little more difficult to read, because you have to know that it was aseptically processed, no sterility test was passed, and then we go, okay, but was it from non-sterile origins or was it from sterile starting components? And that's where the BUD would change, right? So let's just go through one. Aseptically processed, I did not pass the sterility test, but I did make it from a non-sterile. Okay, at room temperature, I get 1 day. At refrigerated, I get 4 days, and frozen, I get 45. Very close to what we currently have. All right, so if I aseptically processed it, I didn't pass sterility test, but it was only sterile products that I used. I get 4 days at controlled room temperature, 10 at refrigerator, and 45 at freezer. Very close to where we currently are already. All right, so now let's go down to aseptically processed, but I performed and received a passing sterility test, then that would be 30 days, 45 days, and 60 days. So once you break down each section, it's easier to read. You read the table the same with terminally sterilized CSPs. No, we get 14 days, 28 days, and 45 days. Terminally sterilized CSPs, if I passed the sterility test, if I performed and passed the sterility test, then I get 45 days, 60, and 90 days. And again, the disclaimer is on there that says if it's physically or chemically not stable, you must give a lower BUD. Next slide, please. All right, so Category 3, there are a lot of requirements in order to establish the BUD. So Category 3, again, is going to have increased facility and personnel requirements. We already talked about the garbing and how our viable sampling and our testing is going to be different. If you are going to do Category 3, stability requirements are there. You must have supported stability data. You must prepare your preparation according to the exact formulation from the stability data. Cannot deviate from your data. Your packaging and stored in the container used in the study So you must actually perform it exactly to how the study was done. Your analytical method must be validated. Your release testing, so what you're going to do after it's done, sterility, it must meet the requirements of 71 or your validated alternative method. Next slide. So when you meet all of those requirements to establish your BUD, under Category 3, the chapter is going to, again, break it into different groups, aseptically processed, sterility tested, and passing all applicable tests. You can have 60, 90, or 120 days. If you have terminally sterilized, so again, aseptically processed is going to be sterile products or it's going to be filtered, and then terminally sterilized, passed your sterility test and all applicable tests, you're going to have 90 days, 120, and 180. And again, chemical and physical limits do apply if they're there. Next slide, please. All right, so there is additional requirements if you are choosing to make a multi-dose. There will be a requirement to pass the USP 51 test. So this is where it's going to get a little complicated. If you are making a multi-dose, non-preserved, aqueous topical and topical ophthalmic CSP, there is a whole section that applies to those types of ophthalmics. So if you are making that, please take time to review that section. Next slide. All right. So the chapter breaks down compounding with a conventionally manufactured product and compounding with a CSP. So in general, compounding with a conventionally manufactured product, you're going to take an FDA-approved product, you're going to manipulate it, and this tells you how you can use it. This is not a whole lot of new information. So obviously an ampule is immediate, single dose vial, you're going to get 12 hours as long as it's entered in an ISO 5. Multi-dose container is going to be 28 days per the manufacturer. Pharmacy bulk package is going to be per the manufacturer, but pharmacy bulk always must be entered in an ISO 5. Next slide, please. All right, so use of a CSP as a component. So this section will address if you're making intermediate. So you have to make a concentration of something that is 100 per 1, but you actually need a 10 per 1 in what you're going to dispense to your patient. So you would make a CSP to make a CSP. So that's where section 16 comes in. So if you're going to make a multi-dose CSP, it must still have that 51, the antimicrobial effectiveness testing. It must obviously be stored properly because it's very important. If your multi-dose is assigned to be in the refrigerator, it must be in the refrigerator or else the BUD is not going to be valid. Once entered, must not be used longer than the BUD of 28 days. In-use time will not limit the BUD of the final CSP. It's very important that if you are doing this practice, you understand what all of this is meaning. Far beyond what I can go over today. But please keep in mind that there is some little nuances in here. Single-dose CSPs and compounded stock solutions must be entered in the ISO Class 5 and can be stored, or excuse me, can be used for up to 12 hours. Again, in-use time will not limit the BUD of the final CSP, but they must also be stored properly. Next slide. Okay, so new terms in many pharmacies, quality assurance and quality control. Quality assurance is a system of procedures, activities, and oversights that ensure the compounding process consistently meets quality standards, whereas QC is the sampling, testing, documentation of results of that taken together to ensure specifications have been met before the release of the CSP. The chapter requires this to be formally established and documented in SOPs. It also formally requires the review of this every 12 months. Next slide. All right, notification about recalls and out of specification. If your product is dispensed before the release testing is known. So in California, we've never allowed that, but the chapter does elaborate on that. So if you release it before your sterility test comes back, you must be able to immediately notify the prescriber of the failure of the specifications and the potential harm caused to the patient, recall of any unused dispensed CSPs, and quarantine any stock remaining in the pharmacy, investigate if any other lots are affected and a recall is necessary. Your SOP must contain the procedures to determine the severity of the problem, procedures to determine the distribution, identify the patients who have received it, and the disposal and documentation of the recall, to investigate and document the reason for the failure. So the chapter really requires you to look at the possible things that may happen and have a plan of action before they happen. Next slide, please. All right, complaint handling. The designated person, and this is the first time we've talked about the designated person, must review all complaints. There must be a key person that understands what the complaints are, and they must actually investigate anything related to the quality. Adverse event reporting, it must be reported. We have laws in California that have required this for a while, but the chapter is now requiring it as well. Next slide, please. Packaging. So this is something new. It's kind of been in the chapter, but it's much more clear now in the chapter. Packaging should protect from damage, leaking, contamination, degradation, and absorption. Appropriate shipping containers and packaging materials must be selected. So if you are mailing a vial from North Dakota in the dead of winter, you probably should know whether your packaging is going to allow that product to freeze. And if it does allow that product to freeze, what the plan is and if it's okay. So the chapter doesn't dive into every possible scenario, but if you are shipping, I don't know, from Arizona and it gets stuck on the FedEx truck in the dead of summer, you need to know if your packaging will allow degradation of that product due to the temperatures. So shipping and transportation must select modes of transportation that are expected to deliver properly packed CSPs in an undamaged, sterile, and stable condition. We see a lot on this where it's just dropped at the front door and the person is at work and it was supposed to be refrigerated upon receipt and it was just dropped off and now it's been outside in, you know, Death Valley for 5 hours. So please keep that in mind. The chapter is now addressing that and it will need to be looked at. And next slide. All right, documentation. Okay, so my soapbox on this is if you wrote it down, you must keep it. The chapter goes on and on and on about requirements and the SOPs and documentation and logs. So if you wrote it down as a course of practice, please keep it. Next slide. Yay! How'd I do? All right, there we go.
Wow. Thank you, Dr. Acosta. I know that this has been a lot of material, and for many people watching and here in the room, we've been watching USP over the years getting to this point, so hardly any of this is a surprise, but it certainly is a lot. And I'm sure those of you who have never seen the USP are probably a little overwhelmed and feel free to continue to ask questions and to learn from what others are doing. So members, we had a very quick, really, when you look at what USP is, summary of the USP language from Dr. Acosta. Do you have any questions or comments for her? How's that? Thank you. You said it 3 times.
I also say thank you, Christine.
Yeah, great presentation.
Great. So we are ready for public comment. As a brief reminder, public comment is an opportunity to provide comment on the information presented and is not a question and answer session. As indicated in the meeting materials, USP does have an FAQ available on its website and is also, I think we attached it to the meeting materials. Are there any public comment from people in the room? Okay, seeing none, moderator, I think we're ready for a public comment for your WebEx.
Thank you, Madam Chair. I've opened up the Q&A panel. If any member of the public would like to comment on agenda item 4, please type comment using the field in the lower right-hand corner of the screen and submit it to all panelists, or simply raise your hand. We are displaying instructions. I do see, oh, we did have a raised hand. Okay, Jeffrey Nahira has a raised hand. Jeffrey, you should be able to unmute yourself. There you go.
Hi, can you hear me okay?
Yes.
Oh, excellent. Thank you. I just wanted to comment. Thank you, Christine, for a great presentation. I just wanted to point out that as part of the new USP regarding demonstration of competency in garbing and hand hygiene, it does state that microbial identification of the colony forming units is not required for fingertip and thumb sampling in the new USP.
Thank you, Jeff.
All right, the next request for comment is from Susan Bonilla. And Susan, you should be able to unmute yourself. There you go.
Susan Bonilla, the CEO for the California Pharmacists Association. We did submit a letter that went into a great deal of detail for your consideration. But kind of overarching, the one comment I did want to make verbally is that we really want to be focused on clarity, on communication, and particularly around knowing the difference between guidelines and actual regulations. And we do feel that guidelines, the USP guidelines, serve a very helpful purpose for pharmacists. And we would just caution pulling guidelines down into regulations, because that immediately creates some confusion on behalf of the pharmacists when they, there could be a lack of clarity there. So we'd really encourage, as we go through this process, that we focus a great deal on making sure that the regulations are crystal clear. As you'll see in our comments, many of them go to the specifics of language used, and of course this is the realm the board deals with all the time, and we do appreciate the inclusive nature of you taking our comments into consideration. Thank you very much.
Thank you.
All right, this is the moderator. I see no further requests for comment. Shall I close the Q&A panel?
Please do. Thank you.
You're welcome.
Before we begin our next agenda item, which will be very comprehensive and probably take us through the afternoon, I think it's prudent to take at least a 10-minute break at this point so that we can stretch our legs and be prepared for the discussion that we have in our next agenda item. So we'll come back at, let's come back at 10:30. Okay, welcome back, everyone. We'll take a quick roll call for attendance. Jake Patel.
Present.
Renee Barker. Present. Sung Oh.
Here.
Great, everyone's here. We'll move on to agenda item 5, discussion and consideration of proposed addition to Title 16, California Code of Regulations, Section 1736, related to sterile preparation. As we continue our work today reviewing the various USP chapters and review current and proposed regulations that may be necessary to implement, clarify, or to make more specific requirements related to the respective chapters, as I stated in our last discussion, oh my goodness, what happened here? Sorry. I believe it's appropriate that such regulations mirror the structure of the respective chapters. This means that the numbering format and section titles for the proposed regulations will mirror the USP chapter. Just to be clear, our goal is to not reiterate the provisions of federal law or USP language, but to clarify or to make more specific the requirements. If no clarification is needed or no additional requirements are necessary for public safety, there will be no additional language proposed. As I stated as a part of my opening remarks, the board is a consumer protection agency. As we consider development of regulations, it will be through the lens of the board's consumer protection mandate, as the law makes it clear that whenever protection of the public is inconsistent with other interests sought to be promoted, the protection of the public shall be paramount. This is a dynamic process, and individuals will have opportunities to participate throughout the development and rulemaking process. So what that means is that we will be discussing these proposed regulations at future meetings, and then they'll be proposed as a regulation. And then there's the regulatory process, which has multiple hearings. So we'll have multiple opportunities to talk about this. Licensees of the board generally must comply with a myriad of state and federal laws. At times, a licensee may be so focused on a specific section of the law that they forget the larger picture and other provisions of law that may be relevant. We see this in several areas of pharmacy practice, but it is most pronounced in compounding. I'd like to remind everyone of the excellent overview that Counsel Eileen Smiley provided at our January 2023 meeting. She covered the requirements for authorized individuals to qualify for some of the exemptions to federal law under provisions of Section 503A. The live stream of this meeting and the presentation slides are available on the board's website. I encourage individuals interested in this area to watch the live stream recording available on the website. It's important to emphasize a few points again. First, the committee will not be looking to add regulation requirements already laid in USP chapters or federal law. The committee is generally focused on detailing additional California state requirements related to changes in USP chapters. Secondly, these discussions will also be dealing with the standard for compounding pharmacies and compounding pharmacists operating in compliance with the exemption of Section 503A of the Federal Food, Drug, and Cosmetic Act, and not with 503B or outsourcing facilities. 503A is quite extensive, but I feel it's appropriate that I highlight one of the specific sections a licensee must meet in order to be eligible for the exemptions under 503A, that the drug product is compounded in compliance with USP chapters on pharmacy compounding. It's important that members and stakeholders understand as we begin our discussion today. Business and Professions Code Section 4126.8 explicitly states that the board has the authority to enforce all USP chapters where incorporated by reference in pharmacy law and its regulations. The board also can add additional requirements to USP language. It cannot promulgate a lesser standard in its regulation. Based on the written comments received in advance of the meeting, I believe that there may be some misunderstanding, so I wanted to make that clear and do some level setting before we start our discussion. Again, before we begin, I want to ensure that members received all of the written comments that were received in advance of the meeting. I'd like to thank all the, did you all receive the letters?
Yes.
I'd like to thank all of the individuals that submitted comments in advance. As a result of the comments submitted, we considered various sections, and I'll be recommending changes to be made in part to address the issues addressed in your comments. These are complex issues, and having input from stakeholders in advance of the meeting is extremely valuable in this process. With that understanding, unless members, do you have any questions, I suggest we begin. Okay. As at the last meeting, I intend to discuss each section first as a committee, then ask the moderator to open for public comment at the Sacramento location, followed by WebEx. We can refine language through our discussion, and with the understanding that any language we amend today will be reviewed by council. Following the end of public comment, I will summarize the comments received for each section, and we can determine if additional changes to the proposed language are appropriate. I've requested staff to display the language during this portion of the meeting to allow edits to be made during the meeting where we believe changes are appropriate. There are also areas where I believe a development of an FAQ may be appropriate to assist licensees. I'll identify those areas in the respective sections and would encourage you to help us to identify any FAQs that you believe are appropriate. Staff will make those as well. As previously stated, this is the beginning of a regulatory process. There will be additional opportunities for board and public to consider the language and provide comments. Also, to many of us, there may be new concepts discussed today. In addition to relying to our own expertise and understanding, Supervising Inspectors Acosta and Penella Spangler, sitting right over there, are available to assist us with their technical input. Are we ready to begin? That was a lot of preview, but I think that'll get us going on a smooth foot here. The first proposed change, as you will note, is to repeal current Article 7 and Section 1751 through 1751.10. The new sections 1736 to 1736.21 are proposed to be added to Article 41. And you can see, this, as we said, displayed on the screen will be the sections that we talk about. Proposed Section 1736 includes definitions beyond those established in the USP chapter. As the language has been publicly available for some time, I'm not going to review each definition, but will highlight a few items. Similar to the proposed language in 1735, the board's definition of essentially a copy of commercially available drug incorporates a requirement for the deviation to produce a clinically significant difference in the patient. Further, please note that the proposed definition of a designated person does not limit the type of individuals that may serve in such a capacity. However, it does make specific that where clinical judgment is necessary, the designated person, and a designated person is not a pharmacist, the PIC will review the practices that require professional judgment. I note that some of the comments we received specific to the definition of essentially a copy do not appear to be relevant to the regulation language that we are considering today, but they were related to non-sterile compounding preparations. However, other comments offered appeared appropriate in lieu of the term comparable, and language displays include some of the updates to the language. So you can see the track changes on the screen, and those are the updates to the posted language that are a result of letters that we received from members of the public. Okay. There were a few comments regarding the proposed definition of the certificate of analysis. Having considered all the comments received specific to the proposed definition, I am most comfortable with the language offered by Rick Rhodes. I will note that at my request, the language being displayed incorporates some of the language changes that were offered by Dr. Rhodes. Further, the display language is offering update to the definition of quality. Again, this is in response to the written comments. A lot of scrolling here, but this is a big section here. I'll give it a few seconds here. You will note that compounding is not defined in this section. This is an example where it is recommended that additional regulation is not necessary. Rather, the board will rely solely on the definitions in federal law and USP. As a quick reminder, federal law states that the definition of compounding does not include mixing, reconstituting, or other such actions that are performed in accordance with the directions contained in approved labeling provided by the product's manufacturer or other manufacturer's directions consistent with the labeling. As included in the meeting materials, USP defines sterile compounding as combining, admixing, diluting, pooling, reconstituting, repackaging, or otherwise altering a drug product or bulk drug substance to create a sterile preparation. You will also note that I'm recommending that the definition of preparation be removed. This is another change I believe that is appropriate based on the review of the written comments we received in advance of the meeting. I believe the proposed language in 1736, as displayed, is appropriate both legally and for consumer protection. Thank you for your patience as I shared my thoughts on the draft regulations and the comments that were received to this section. Did everyone have an opportunity to see the changes on the screen before we move on to comments? Increase the font. So everyone in the room, have you had a chance to see the changes with the track changes, or do you want to go over them again before we go on to comment? Seeing no comments in the room, members, do you have any questions or comments to the proposed section 1736?
Just want to say thank you to Chair Serpa and all our inspectors. Thanks for all the work you guys put in. I'm sure countless hours went in there, so thank you guys. Looking forward to this discussion.
Yeah, I'll also echo that. Thank you, everybody. I know there's been a lot of time put in by that, and I do appreciate the comments. I do have a comment for certificate of analysis. So apart from being related to a pharmaceutical, it also applies to commercial sterile growth media. So if USP 2.3 has a certificate of analysis must be obtained from the supplier. So in this definition, it's not, somebody's looking at that, it's a different type of C of A, right? I mean, so this one is a component, the certificate of analysis here, that you're ensuring that the component demonstrates that it will, so it's suitable for use in pharmaceuticals, but it's also required to be reviewed and obtained for sterile media. So if you look at the USP definition of certificate of analysis, it's much more general, doesn't include being part. So
does it include the what?
It doesn't include being part of a pharmaceutical of the C of A, because it's not, since it's it's for the sterile growth media.
So that's an excellent point. I think we were looking at the COA and trying to beef up the definition in light of some of the problems that we've had with components. But regarding sterile media, I don't think we had that discussion. Dr. Acosta or Ms. Penella Spangler, do you have any questions or any comments about that? How we could include media somewhere?
So maybe we change the word component to something like the article, because the article is a more general kind of CGMP term to anything. So like the item we are addressing. So it could be the container closure is an article, the component, the API, they're all different terms.
So just as so from the USP glossary, has a report from the supplier of a component, container, or closure that accompanies the supplier's material and contains the specifications and results of all analyses and a description of the material.
Yeah, so we're looking again at not repeating what's in USP, but to add.
Sure.
So this is to be more specific. So would changing the word component to article allow that expanded definition to work?
I had a suggestion. I don't think this has changed. I mean, I didn't have the updated at the time, but basically to just have a first sentence that's the certificate of analysis means a document produced by the manufacturer that certifies the quality of the component and demonstrates that the component conforms to the defined specifications. For API, the C of A also certifies that the component, blah, blah, on into this currently written definition.
I think the intent is there, and I think we could probably work with the supervising inspectors to include that that gap. So I appreciate that. We'll take note of that, and we'll work on that and try to work with our attorneys and counsel to make sure that that meets the intent that you've mentioned, that we have a gap and that is appropriate legally. Thank you.
I have another, it's very small, but I feel like it is a little more appropriate, just a small edit for designated persons, when the designated person is not the pharmacist, but a pharmacist. The pharmacist.
Thank you.
It
Yeah, that's
like it's something
better.
A specific pharmacist or something, so just a pharmacist.
Thank you.
That's all I have for that section.
Thank you. Members, any other comments? Okay, moderator, let's open the line. Moderator will ask for public comment in the room. Any public comment in the room?
Yeah. He had a comment.
Please approach if you have comment. Can you hear him? Just a moment. He's going to help with the microphone.
There we go. Hi, my name is Peter Koshland. I'm a compounding pharmacist. My understanding of this regulation is that it codifies a disallowance of compounding drugs that are on the FDA's Category 1 bulk substance list. I don't know if you're familiar with that list. I can explain it a little bit more if you need me to. Very, very concerned that this will cause a lack of access and therefore patient harm. And really implore the members of this committee and the board as a whole to take any decision that may remove a drug from the public very, very seriously, because that action may have very harmful consequences for the citizens of California. The FDA has allowed compounding of drugs on this list and has evaluated every single drug and has actually removed drugs from the list that they had felt that do not have safety or clinical utility. They're currently deliberating on this entire list and will make final decisions in the coming years to put them either permanently on the canned compound list or on category 2, which means that we cannot compound with that drug. You may hear that chemicals that are used in this are not USP monographed and therefore are putrid or contaminated, but we haven't seen any evidence presented to the public as to that fact. And most of these drugs that we have looked at have been in compliance with other pharmacopoeias, like the European Pharmacopoeia and the Japanese Pharmacopoeia, which have similarly high standards to the United States Pharmacopoeia. The only issue I'm aware of was a contaminated glutathione that was compounded by a pharmacy that caused some patient harm. However, this contaminant would have been caught if that pharmacy had actually done endotoxin testing on their finished product, which is currently required by California law. If we're going to remove access, we must carefully weigh potential harms. And there are some medications on that list that are very significant to patient health. Some medications are used for lupus patients. There's one medication that's used for heavy metal toxicity for acute poisoning that must be compounded as an injectable to save a life. So again, just imploring you and encouraging you to be very, very deliberate about any action that would remove a bulk substance from our ability to compound and take care of our patients. You may also hear that some medications are best compounded by 503B pharmacies because they must adhere to higher standards. I think with some of the new USP regulations, those standards are becoming closer, which we are happy to see and adhere to. But more importantly, the US 503B pharmacies.
10 seconds.
I'm just going to end it with that and saying there's an important role for 503A to be able to provide these medications and to be able to, eliminate any patient harm from lack of access.
Thank you. And just to remind everyone, we are going through each section one at a time, so you may want to make your comments in that appropriate section.
I'm sorry.
Right now, we're going over the definitions.
Okay.
Thank you for your comment.
You want me to come back and say all that all over again?
Not necessarily, but you may want to include your comments in the section that is appropriate so that we can consider it at that time.
Okay.
Hello again, Marie Kottman with Pacific Compounding Pharmacy. With regards to the efforts that you guys made to incorporate comments, thank you very much. I appreciate all the extra effort that you've done since the meeting materials were put out. With regards to the certificate and analysis, I think it gets a little confusing when we start talking about a COA from the supplier must include the name of the manufacturer. When included in 4033, manufacturer already includes someone who repackages any drug or device. So for instance, if I were to buy an API from PCCA, they will not tell me what company they bought it from nor what origin that is, but PCCA should be allowed to be the manufacturer based on our existing law 4033, unless there's something I don't understand there. So that's something to just, it makes it more confusing to put in supplier and manufacturer under a C of A. Secondly, with regards to COA in USP 797, section 9.2 and 9.3, they make a clear distinction between supplies and components, and they talk very clearly, and I won't read it to you, but there's information about APIs and all other components other than APIs and what quality they must meet. So it's actually already in 797, which will be codified as of November 1st. we can't see very much of your edits, so moving on to essentially a copy. I had submitted some comments on that, and okay, include the same API. Great, okay, so that's it. Is there, for your discussion, is there a reason that we are still making this different than the FDA's guideline already of what is essentially a copy? Why are we trying to, as a licensee, it is hard for me to go to two different sources to have to try and figure out what it is when it's so clearly defined in a, what is it, an 8 or 10 page document? Clearly defined, right? But it's really discussed, and why is essentially a copy? What does it mean? How are they, the FDA, going to enforce this? Is California intending to enforce it differently than what the FDA already defines? If so, maybe that's what you should say, is we would like to go above and beyond what the FDA already has in how it defines essentially a copy, and this is what we expect. That would be much clearer as a licensee to be able to read it that way. And there's so much in this section, I think I'm going to let my comments stand for the rest. Thank you very much.
Dr. Cotman, what was your first comment? The first one? Can you remind me?
With regards to the COA?
No, the very first thing you said, because I was going to say something and I didn't write myself a note to respond.
I said thank you for putting extra effort into this. And then with regards to the COA, it was with regards to the supplier versus the manufacturer.
Okay, that's right.
Yeah.
Thank you.
So, yeah.
Thank you.
Thank you very much.
For your comments. And I guess it might be easier to respond a little bit at a time because there's probably going to be a lot of different comments. But the intent is if it's a regulation that's here, it's because it is different than USP, and typically it's a higher standard. So that's why it is here. If it's not here, then it's the same as USP. And I don't know, Dr. Costa, did you want to talk about the reason why the manufacturers required that we didn't want the repackager solely, that we wanted the actual manufacturer?
Right. So there is a difference between a manufacturer and the manufacturer. The FDA will register people as a manufacturer, but it does not mean they are the manufacturer of the product. And so here, we're talking about the manufacturer, the actual person that manufactured the product. A supplier may be registered with the FDA as a manufacturer, but they are not the actual manufacturer. Think about it like a car salesman. I may go to a Kia dealer, but on their lot, they may sell all these other brands of cars, right? They're still dealing the car, but they are not the manufacturer. So we want the manufacturer. Yeah. And so I don't have any issue with the supplier being removed, but sometimes that's actually the C of A that is presented.
Thank you. Do you have any other comments from people in Sacramento? I'm sorry. Let's go to WebEx.
Thank you, Madam Chair. I have opened up the Q&A panel. If any member of the public would like to comment at this time, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists. And you may also just raise your hand. Our first request for comment is from Keith Yoshizuka. And Keith, you should be able to unmute yourself.
Give your hand up.
California Society of Health System Pharmacists. Regarding the definition of certificate of analysis, I am advocating to keep the amendment in there saying or supplier, similar to CPHA. You should be able to get the information, for example, if the wholesaler has it, and it would be the document, of course, from the manufacturer, but it looks like, or could be interpreted, that we would have to get it directly from the manufacturer as opposed to somebody else that has the information. Thank you very much.
Thank you.
All right, the next request for comment is from John Gray. John, I'll let you know when you can unmute yourself. All right, John Gray, you should be able to unmute yourself.
Hi, good morning. This is John Gray. I'm a registered pharmacist with Kaiser Permanente. Just one comment on item C, the definition of designated person or persons. We believe that the phrase, when the designated person is not a pharmacist, the pharmacist in charge must review all practices related to the operation of the facility that require professional judgment, probably does not provide the level of clarity that the regulated public requires to implement this requirement. We recommend that the board clarify the specific practices that must be reviewed by the PIC if the designated person is not a pharmacist. One possible approach could be to reference Business and Professions Code 4051 for practices that must be reviewed by a pharmacist, as those are, as that section of code cites practices that are limited to the pharmacist. Another approach, I guess, could be to have a licensee specify in their standard operating procedures what elements they believe require the professional judgment of a pharmacist and therefore must be reviewed by the PIC if the designated person is not a pharmacist. And we also recommend that the board specify the nature of the record that is required to document the PIC's review of practices that require the professional judgment of a pharmacist. It's not entirely clear what kind of record the board and its inspectors will expect to see in these situations. Thank you very much.
Thank you.
All right, the next request for comment is from David Poor. David, you should be able to unmute yourself. There you go.
Hope you can hear me okay. My name's David Poor. I'm a partner in the Washington, D.C. office of the Hans Scarborough Law Firm. I serve as Legislative and Regulatory Counsel for the Alliance for Pharmacy Compounding. APC is a voice for pharmacy compounding, representing compounding pharmacists, technicians, and 503A and 503B settings, as well as prescribers, educators, researchers, and suppliers. We really appreciate the opportunity to give our input to the board today. We've got, comments on several of the proposed changes, and I'll limit my comments right now to the sections, the definition sections that are under consideration, and would like to echo the previous comments, thanking the board for incorporating some of the input you've already received. APC shares some of the concerns raised with some of these definition changes. In particular, the certificate of analysis, we agree that including the supplier makes a lot of sense and support that proposed change. As it relates to essentially a copy, we were going to raise concerns with the inclusion of the word comparable and kind of the vagueness and subjective nature of that, and would agree that includes the same API as an improvement there. So we would support the board's change there. One comment, additional comment on the essentially a copy definition referencing a commercially available drug. We have heard some concerns that this would include drugs compounded by outsourcing facilities under 503B, and would suggest that perhaps FDA approved might be more specific there and exclude drugs compounded by outsourcing facilities. Those are our main comments on the definition section. I will reserve our comments on other proposed changes until those sections come before the board. But again, thank you very much for the opportunity, and we appreciate the incorporation of the input you've already received and associate ourselves with some of those concerns that were raised.
Thank you.
All right, the next request for comment is from Mark Wagner. Mark, you should be able to unmute yourself. There you go.
My name's Mark Wagner, and I'm an associate with the law firm Baker Hostetler out of our Washington, D.C. office. In your opening remarks, you mentioned that this proposal applies to Section 503A compounding and not 503B or outsourcing facilities. I thank you for that clarification. It's also my understanding that Section 503A does not apply to compounding for animal patients. Instead, Section 503A compounding only applies to human drugs. For animal or veterinary compounding, the FDA relies on GFI 256, which FDA will begin to inspect for compliance beginning next week. Can you please clarify that the intent here is that animal or veterinary compounding is not subject to the proposed regulations? because if this proposal does apply to animal or veterinary compounding, there would be many conflicts between the proposed regulations and GFI 256, which I'm happy to get into the differences, but I'll reserve these comments for later on.
Thank you.
All right, this is a moderator. I see no further requests for comment. Shall I close the Q&A panel now?
Please do. I
Okay.
think it's appropriate for me to make one comment that we are the Board of Pharmacy, and so we're looking at practices within pharmacies, that if they are doing veterinary compounding within pharmacies, that's within our purview. Supervising Inspector Acosta, do you want to clarify if I've made any mistakes there?
No, I would just say these regulations are going to be human and vet products.
Right.
We don't differentiate by the patient population.
Thank you.
And we are very aware of GFI.
Thank you. So to, I think it might be helpful to summarize the tasks for this section, and that is to make some additional changes with 1736A to deal with the COA for media and potentially some supplies, and so we'll work on that, and then changing of the word the to A in section C. Moving on, let's move on to, thank you everyone for this robust discussion here. I think it will get to be more challenging as we move on too. Moving on to section 1736.1, sterile compounding scope. I'm comfortable with the language and appreciate the clarity being provided specifically on immediate administration requirements that specify that it should only be done when failure to administer the preparation could result in the loss of life or intense suffering. This is also an area where I believe an FAQ is appropriate. As members, we have reviewed enforcement cases where licensees were using the immediate use authorization as their standard practice, rather than using it for immediate use authorization as it was intended. The FAQ should include examples of the documentation required, such as inclusion of the required information in the patient's chart. So this is an area that came up as a question. So as a response to written information on this area, I'm suggesting a slight alteration to the language to make this concept more clear, that we're not asking for additional documentation for immediate use. This kind of documentation should be available in the patient's chart, and that could be readily retrievable, not as a separate document. That's not required. Also want to highlight that where appropriate language is proposed is consistent with language included in the board's proposed non-sterile compounding regulations. As an example, section 1736C, you will note there's an edit necessary to update the language from non-sterile preparations to reflect sterile preparations. In addition, based on the written comments, I'm recommending the slight change in the language. I believe an FAQ is appropriate for section 1736(1)D. This is again an area where in reviewing enforcement matters in response to the written comments received, I agree with the recommended language that is included in D2 and D3 and clarify the concept in D to assure consistency in the language. So we have a few changes here that are displayed on the screen. Everyone had enough time to see the changes that have been made from these are as a response to the written materials, to the written comments that were received before the meeting. Members, do you have any questions or comments in this section?
Can we see it from the beginning? It's kind of hard because you can only see certain parts. So since this is also new.
Let's start from the beginning of point 1. So the first change that's there is it clarifies that another document is not needed, that this information should be available in the patient's medical record. That was in the response to, we were going to do an FAQ on that, but decided that regulation may be helpful because people may not understand that there's an FAQ that would clarify that. Let's go on to the next one. That was a typo, and then a clarification of individual to types of patients. And then the next one, it's a lot of red, but it's really not that much in detail here. It was dividing up the information into a list, 1, 2, and 3, instead of it being all written out, and separating out the documentation as a C. We may need to work with an attorney to deal with how that is organized, but we tried to put it in some sort of outline format to make it easier, but we wanted to make sure that it is appropriate legally also. So essentially a copy is A, as no change, B, with some minor changes to clarify the language and ensure consistency with other parts of the regulation, because this is also in another part of the regulation. And then lastly was as per one of the recommendations from the written comment was to change the word intended to suitable, which we thought was a great one, and then to further clarify that allowable under the Animal Medicinal Drug Use Clarification Act. That was just to add clarity to any areas where veterinary compounding is done. I think that was it. So Renee, I'm sorry, dumping all these changes on you. Renee's our compounding expert, so she knows these things backwards and forwards. Are you okay? I mean,
we all know how challenging this is.
I don't want to rush you.
Yeah.
You can also make comments after public comment too.
Okay, so for C of 1736.1C, so based on the documented prescriptions of those patients. So I think that's better. I'm just wondering, sometimes the focus is really on the drug product that's being compounded. And it could be for like various, multiple different types of patients, like in an anesthesia situation or something. So types of patients, is that like the category of diagnoses or like patients of a particular type of physician?
Yeah, and I'm open to another word. I think I was trying to make it more broad because at first, when you first read it, it seemed like it had to be very specific individual patients. And it's more of the patients. So if I am compounding cyclosporin, for example, and I have a lot of different diagnosis patients, it would be patients who are receiving injectable cyclosporin. It wouldn't necessarily be their diagnosis or their age or anything like that. It would just be patients who qualify in that way, rather than saying that I had Jane and Mark and John and Mary, and those 4 people, and I'd make enough just for those 4. It was trying to be a little bit more broad, but open to change in wording. And Supervising Inspector Acosta, did you want to comment too?
Patient population. So the intent is if a pharmacy routinely compounds something, that they would be able to have it in stock because they know the type of patient that needs it would come. So if you're next to Rady's down in San Diego, you know they're going to come for a certain pediatric concentration. You don't know which patient's coming that day, but to allow you to compound that. So the patient population instead of type of patient, if that helps.
Patient population?
Yeah. Again, I was in my mind kind of focusing on what types of products they need. Sometimes that's kind of, anyway, I think that fits it. I think that would fit it for population.
Okay.
Just to be very, very general.
Yes.
Yeah.
Thank you. Son?
Are we addressing comments
we
about
can go
the
back to-
shortage?
I'm sorry?
1736.1 D1A about the comment about the shortage. I mean, I would like to make sure that people can compound that's not only on that list. If there is, because things are so dynamic. What if it's not on the list yet, but they just discover that it's going on the shortage by their supplier and there is a need for it? Are we allowing that to happen? I mean, it's kind of...
Go ahead.
So because a supplier or a wholesale doesn't have it, doesn't necessarily mean that it's in shortage. So you can report a shortage to ASHP and they put it on rather quickly, is my understanding. So that's very short turnaround. The FDA list will only list things the FDA deems as like necessary. So that's why adding the ASHP gives a lot more flexibility. It does tend to turn over much quicker.
Okay.
Yeah, that's my concern, because there are times where your wholesaler might not have it, but there are other suppliers that do, and that should not create a opportunity to compound because you're specific. One place that you check doesn't have it.
But that the pharmacy can't just go find a new supplier. So like,
They do.
I mean, if it's something that's an immediate need, like, don't we want them to be able to get the supply to patients?
Or do we want them to send to a pharmacy that can get the manufactured product?
Is that I'm
So
not.
in general, if something is available, then a pharmacy should be able to get it. But just because you have a contract with one wholesaler doesn't mean that that can be the only way to get the product. There are certain branded products that they only will distribute to certain pharmacies because there's contracts. Just because you don't have that contract and can't get that branded product should not make it so you can compound that product.
Yeah, I totally agree that it shouldn't be convenience or cost savings, but I just want to make sure that if something is not available for you to order, that they need to be able to produce somehow for that patient. So I just want some flexibility, that's all.
Well, and I do see the point. I think the balance there is, we do have the certainty or the understanding that the ASHP list is something that is updated very quickly. And it's also something that they put things on there before pharmacies even notice that their wholesaler is out. They're already tracking it. The other part is by opening this up, it creates a potential of abuse that is beyond where we would be able to control. And that is something that is already enforcement issues with the current list, where we know that there are people out of convenience or business reasons or all sorts of non-patient care kinds of reasons are compounding, that we are trying to limit that down to the actual need and patient access.
So I will just add, I just hope that this won't cause any delay care to patients. That's the, I would hope that we would be very cautious about enforcing this action if there was a situation that we discover that they were making something, but then it was legitimate need for that patient. That's the only thing that I'm concerned about. If the patient needs something, I think we're all dealing with large businesses. It takes a lot of processes to change things in these situations. So as long as we're mindful, that's my hope.
So I also wanted to comment on that because in my personal experience have found that that's not always as responsive, the ASHP list. And also, at times, rather you reach out beyond your contracted wholesaler and cannot acquire it. Also, it can be taken off the ASHP drug list and you still can't get it. Sometimes things are taken off what seems like early, not always, but it definitely has happened. So there will be, possibly little gaps in there where you're all of a sudden you can't get it. And then it shows up on the ASHP drug list. That's actually been not uncommon. And then at times it's taken off and then it's not being able to be purchased. So it really, and then to his point, being able to pivot is a challenge. When you're told, it's 2 weeks, you'll be able to get it. So again, in your different settings, when you have a patient who needs it and they're right there, like you have to make something. So,
do you have an example of a drug that you would then compound? Because I guess my question is I do see all those as the absolute reality, but the question is then would you be ready to go and compound it as a practitioner? To me, compounding something when you were using a commercially available product and then just switching quickly to take care of a patient, you have to have a master formula. You have to work through how you're going to compound it. So, I mean, compounding is great, but I mean, we can have some of the practitioners in the audience tell us it's not something that you would normally do overnight. I mean, it may be. Do you know what I mean? Like
I see both your points, but I think that perhaps we need to talk a little bit more about this and maybe having some sort of FAQ with some specific examples, because having some flexibility is important, but with the regulations, sometimes opening the door just opens it too much. But to Christine's point, I think that what Renee may be talking about is like you purchase a pre-manufactured Nafcillin, for example, 2 grams in 100 ml normal saline, and that's not available anymore. So now I'll just be using a Nafcillin vial and adding it to my own piggyback. So I'm compounding it. That, I think, is not the intent here, to be micromanaging that to that extent. It's more of the other kinds of areas where it's not a shortage of, because then that wholesaler probably will get some tomorrow, so you're just out for the day kind of thing. So would having an FAQ to maybe provide some specific examples be helpful in here to show the flexibility, but also to make sure that that's an area that's not abused? What do you think, Dr. Acosta or Dr. Barker?
I don't think there's anything in the law that would address exactly what you're talking about, a pre-made, like ready-to-use bag, and then going in and compounding with a commercially manufactured product. There's nothing that makes one better than the other, so switching I don't think is within the scope of what this law is envisioning. So maybe an FAQ would be helpful to understand the intent of where the law has been used in the past.
Yeah, I would agree. Yeah. Some FAQs then.
It could be because pharmacists are very, as we all know here and in the audience, we're very detail oriented, and so we are probably taking this to the extreme example, and maybe having some FAQs that we could work on. More members, any other comments? Okay, any public comment in the audience here in Sacramento? You have people coming to the table here?
Thank you very much. It appears that you've adopted a lot of recommendations that have definitely made this much clearer and easier to follow as a licensee. Thank you. On specifically item 1736.1D3, there is a minor change that you made that says is made with a now non-sterile component, which is conventionally manufactured, for which a conventionally manufactured sterile product is available and appropriate for the intended CSP. There are situations where using the sterile to sterile components is not always preferred. There are some stability issues that cannot be validated. Sometimes when you combine two sterile products, where you may have stability indicating information or data already on using a non-sterile ingredient to make a final product for a patient. So I am concerned that the determination of what's appropriate may not be in the hands of the compounding pharmacist, but that it may be in the hands of somebody looking in from the outside after the fact. And so it's pretty broad. It basically says if there's a commercially available sterile product, that you can't use a non-sterile component to make something similar. So I'm not quite sure how to reword it. It was confusing to begin with, and the non-sterile clarifies it more to what the intent was, but I think it's too broad and overreaching, and maybe the intent of what you're trying to do needs to be further drilled down to make this something that doesn't eliminate a lot of the sterile compounding that is done. Thank you.
Thank you. Dr. Horn, did you have something?
Hi, my name is Melanie Horn. I come from Sutter Health, and thank you to the board for making some of these changes, as these are definitely items that have been discussed in depth within our health system and our compounding pharmacists as well. I did want to comment just briefly in regards to the 1736.1B, and I do agree that an FAQ would definitely benefit users. But I do also want to just point out that the situational requirement being so restrictive to the verbiage that has been provided does pose a little bit of a challenge. In the past, the situational requirement of an emergent need, it is not in the best interest of the public to be providing immediate use CSPs for routine care. But the challenge identified is with limiting it to only the scenarios of loss in life and intense suffering, rather than providing a little bit more clarification to the professional guidance or the pharmacist's professional judgment on the care team to make a clear determination regarding risk versus benefit of immediate and direct indication. The language extends this current enforceable and universally applied USP situational requirement to only restrict the compounding pharmacies and pharmacists in California. The provision continued in 1736 restricts pharmacist compounding under these specified and justifiable scenarios to document this, while another healthcare worker, such as a surgeon or a registered nurse, who may have now gotten a one-time facility aseptic training and demonstrated competency, could do this without any other requirement for a situation, scenario, or documentation. And so this imparts a challenge because pharmacy personnel maintain a higher level of ownership and competence in compounding, and this should not restrict their ability to provide quality compounding care services if a true need arises or a great risk or benefit is identified. Clinical pharmacists offer compounding at the bedside. They have a specialized medication expertise and increased competency and skills to compound CSP compared to other healthcare workers. So what I would ask is to consider how we could possibly develop either the FAQ to be very clear. Pharmacists have decentralized and provided compounding in operating rooms, emergency departments, intensive care units with care teams that rely on their expertise when an immediate use CSP is necessary, based on professional judgment, and would meet USP standards.
10 seconds.
It does create some ambiguity and confusion resulting in loss of life or intense suffering. So I just wanted to point that out, and I do appreciate the FAQ and also the FAQ regarding manufactured products
3 minutes
in
are
the
up.
other section. So thank you.
Thank you. Any other comments here in Sacramento?
Good morning. Andre Petersen. I'm a director of pharmacy, also with Sutter Health. And I'd like to first request for each section if we would be afforded the ability to re-queue ourselves, since each section may have multiple items for comment and consideration. My concern is with 1736(1)B, also around immediate use concerns. As a director of pharmacy of a rural hospital, I'm being left to think, how would I be operationalizing the proposed regulation if I run into certain types of problems? In addition to what's already pointed out, my thinking is, what if I'm at a rural hospital without resources nearby when my PEC stops working? And we're dealing with equipment, they do tend to fail, and sometimes something fails for where you don't have a contingency for. So there's got to be a way for us to continue to care for patients in a hospital. Nowadays, patients that are in a hospital are acutely ill. There's rarely patients that are not acutely ill, and any lack of missed doses or lack of medication can worsen their condition. While it's always my goal to provide the highest quality of care, I agree that we always have to make CSPs in the highest possible standards of clean room. I think there needs to be a way for us to be able to take care of patients when we do run into that problems. And immediate use, as it's currently defined, is not going to be allow us to take care of patients. My only option would be to close the hospital, and I think we all agree that that's not an option. The other option is to allow nurses on the units, because they're not following the same regulations as the pharmacists do, to make those medications. And that would put the practice of sterile compounding back to prior to the 1960s. So in essence, that could put us 60 years behind where we currently are today. Again, I would like to request that we strike this section from the regulation. USP gives very clear guidance on immediate use, and they have found that it is safe to allow for immediate use within their parameters, and I would like to recommend that we follow that. Thank you very much for hearing me out. I appreciate it.
Thank you, Andre. I think the issue about facility and equipment failure is discussed in another section, so we'll have an opportunity to talk about that there too. Do you have a comment?
I'd just like to remind the committee that Section B is actually already in current law. It is 1751.8E. It reads almost identical to what is in the proposed.
Yeah, thank you for that reminder.
Christine, if you can do that for us, that would also help. If you can just kind of point out what's already in, because it's really hard to keep up with all these changes.
Any other comments for people in the room here in Sacramento? I think we're ready for WebEx comments.
Thank you, Madam Chair. I've opened up the Q&A. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of your screen and submit it to all panelists, or simply raise your hand. Reminder, the Q&A panel is only meant to indicate that you would like to make a verbal comment. It's not meant for you to type out your comment. And I see we have a request from Lee Rosebush. So Lee, you should be able to unmute yourself. There you go.
Thank you. Thank you. I really appreciate it. My name is Lee Rosebush, and I'm actually the chair of the Outsourcing Facility Association, better known as the OFA. We are the 503B trade association. And I wanted to point out specifically for D1A, if you could scroll down a little bit. I know that there were some comments made, really, specifically the shortage aspects behind it. In this case, there actually is, with the proposed D1A language, a direct contradiction with federal law here, as well as with other California pharmacy policy aspects, as well as regulations that have been put currently in place. Federal law allows an outsourcing facility, which California recognizes and permits specifically, to compound drugs on the FDA drug shortage list. Here, D1A would allow compounding under a less robust quality standard that California has recognized, as well as the FDA has recognized. USP standards are a lower standard than those utilized by 503Bs, which is CGMP. By doing so in this situation, it would allow for 503As to compound an essential copy specifically at a lower standard for those on the ASHP list or the FDA list. This is actually more lenient and at a lower standard than what is currently allowed for 503B facilities underneath California law. In addition, in this case, it would allow for, as I mentioned, compounding of FDA drug shortages, but also ASHP drug shortages, which are also not recognized underneath federal law. Outsourcing facilities can't even do this themselves in California under current regulations. I have concern for the safety of California patients if this allowance was put into regulations specifically. Furthermore, if a pharmacy were to follow this proposed California regulation, they would be in direct violation of federal law, specifically Section 503A of the Federal Food and Drug Cosmetic Act, as well as the final guidance that have been put in place by FDA, specifically for 503A facilities, which do not recognize the ability in this situation to compound an essential copy for either the ASHP list or specifically the FDA list, except for certain limited COVID situations that will be ending with the public health emergency. Thank you.
Thank you.
All right, our next request for comment is from David Poor. David, you should be able to unmute.
Thank you. And just to remind folks, I'm here on behalf of the Alliance for Pharmacy Compounding. Appreciating Dr. Acosta's comments about USP being a floor, not a ceiling, and the desire of the board in some cases to go above and beyond. I think you'll see a theme in our comments to several of these sections about concerns about how inconsistencies between the California regs and USP or federal law or guidance or other states, create a system whereby it makes compliance by licensees more difficult, limits access, and jeopardizes, patient safety in some cases. Specific comments on these sections under 1736(1)C, understanding that these are existing regs, not necessarily a major change here, but we would point out that the system that this reg creates for compounding of sterile preparations for veterinarians to dispense to animal patients does not align with now final GFI 256 on animal drug compounding of bulk substances. FDA's expressed an intent to start enforcing on April 1 that GFI. The system there sets up a framework whereby substances can be nominated to the CVM for consideration on a positive list for office stock of bulk substances. Once those substances are considered and placed on that positive list, there is no 120-hour supply limitation or other limitation on the quantity of compounded preparations that can be provided, and there's no distinction in 256 between sterile and non-sterile. So I would point that out, and APC would urge the board to consider taking a very close look at 256 and, to the extent possible, aligning the regs with 256 to increase compliance on veterinary compounding of bulk substances. Also wanted to touch on Lee Rosebush's comments just now. APC, we intended to also point out the inconsistency with current federal law. Lee's exactly right. I agree with his analysis, but completely disagree with his conclusion that the ASHP list would somehow be inappropriate as a carve out for essentially a copy. He's absolutely right that the current guidance, the federal guidance, now final guidance on essentially a copy and shortages only references the FDA shortage list.
10
APC
seconds.
has long believed that the ASHP list is appropriate, and there's in fact federal legislation, HR 167, that would codify that both the FDA list.
And I'm sorry, the 3 minutes were up. Our next request for
Tricia,
comment.
one thing before we
Mhm.
move on, I just wanted to remind members of the public that are on WebEx to avoid putting your comments in the question and answer. Just put comment, and Tricia will bring you up in the order. And also only put comment in the section that we are discussing. Don't put that you have a comment for a future section. That doesn't get you higher on the list. Thank you.
Thank you. Our next request for comment is from Jeffrey Nahira, and Jeffrey, you should be able to unmute yourself.
Hi, thank you. Can you hear me okay?
Yes.
Thank you. Again, Jeffrey here from NutriShare, and I appreciate that. Sorry, Dr. Sherpa, I guess I'm a little confused in terms of what section we're currently on. I had comments regarding sections 1736.4 and 1736.6. Would this be the appropriate time to bring up those comments?
Right now we're on point 1.
Okay, I will
So,
hold.
thank you.
Sure, thank you.
All right, the next request for comment is from Rita Shane. Rita, you should be able to unmute. There you go.
Immediate use and emergency section.
Sorry, Dr. Shane, can you speak up?
Can you hear me now?
You're
hear me
far
better?
away, but we can hear you.
Oh, wait, 1 second. Is that better? Is that better?
Yes.
Yes.
Okay. So with respect to this section on immediate use, I think the concern is the documentation requirements that could actually take the pharmacist away from direct patient care. And I think consistent with other comments that were made, this is not required by any other health professionals. And whether we're at a code or in an emergency situation, to require additional documentation, which I respect, it may be already in the standards, really does take us away from patient care. Sometimes there are multiple emergencies going on, and no other provider needs to do this level of documentation. So I think it's a disservice to our patients, given that we're the professional with the highest level of competency with respect to this area. I also want to address the drug shortages. There were over 235 recalls last year that affected over 700 NDCs. A number of those are injectables. I concur with other comments that have been made that the ASHP list is not always up to date, and appreciate the FAQs that would enable us to take care of patients. Hospitals are in very dynamic situations. With respect to 503B facilities, based on the evidence that I've seen, most of the harm that has occurred with respect to patients, whether it's NECC or other issues with pharmaceuticals, and more recently with nephron contamination, have been 503B facilities. So I don't think it would be accurate to state that 503As perform at a lower standard. There may be lower requirements or different requirements for what we do, but that's why there are BUDs that support that. And in fact, there's very little evidence of contamination coming out of health system pharmacies on a national basis. So I would just want to state that we need to really be mindful when we're talking about standards of care, because I've been in health system practice for over 40 years, and I do believe that we do provide a high level of care, and that in fact the contamination and the issues that we're hearing about are coming from larger facilities that are well known, and they happen to all be 503B. Thank God there are 503B facilities, but they don't always perform at the highest level of care based on the evidence and the number of recalls that we've had to react to when that does occur, and then we have to scramble to provide compounding services in our health systems that are already strapped with respect to workforce shortages and high census. So I had to express my passion because I disagree with the comments that were made. Federal law notwithstanding, I'm working only based on evidence, which is what I believe we all would like to do when we make decisions. Thank you.
Thank you.
All right, the next request for comment is from Sean. Sean, you should be able to unmute yourself. There you go.
A quick comment in 1736.1C that it looks to me there's a typo where it says regular treatment in the prescriber's officer, as opposed to, I believe it should be office.
Thank you.
All right, the next request for comment is from A. Bendam Kia. A. Bendam Kia, you should be able to unmute.
A lot of comments here.
All right, we'll try that again. A. Bendam Kia, you should see a prompt to unmute. Go ahead and click on that. All right, we will come back. We'll go to the next request for comment from Robert Jackson. Robert, you should be able to unmute. There you go.
It represents multiple smaller hospitals in California. And I wanted to make a couple comments in regards to the immediate use regulation. The first one is in response to Dr. Acosta's comment that it is part of current regulation. And I also wanted to mention that it is obviously part of current 797 as well, but I wanted to make sure the board understands that the 797 revision, it was removed, and the USP committee did specifically remove the language of emergent or emergency requirement. So they felt that it was not required. My second comment is that I did want to reinforce the comments from Dr. Andres Peters, who came up earlier, and say that, you know, there are often times where PECs fail, and we as pharmacists have to figure out what to do. And what has happened many times is the pharmacist says, you know what, I'm scared the board is going to cite and fine me for making immediate use. It may not have been emergent, and so I'm going to hand this kit to the nurse who is not an expert like a pharmacist, who does not have the training that we have. And so I think, and that happens more often than we'd hope. And so I think that there does need to be some provision for the allowance of immediate use, so that we can do things like get outsourcing set up, contracts set up, and that kind of thing. Thank you for your time. I appreciate it.
Thank you.
All right, the next request for comment is from Ricky Rhodes. And Ricky, I'll let you know you can unmute. Okay, Ricky, you should be able to unmute yourself.
Okay, yes, hi, this is Rick Rhodes. Thank you. And thank you to the board and the staff, both for, harmonizing with USP and this process. It's been a very responsive process. And I'd like to see all of the interactions with the regulated public and with the board. It's really helpful to come up with these regulations that are going to work. I do have a comment on 1736.1 DB3 in regards to is made with a component for which a conventionally manufactured sterile product is available and appropriate. I do think it clarified the intent. Am I at the right spot? Let me see.
Just at the bottom. You scroll up a little bit more. Yeah.
To say non-sterile. Am I at the, yeah, I think I'm at the right spot here. I don't see it on the screen. Is it D?
It should be on the screen.
Okay. Well, I'll go ahead. I don't see it on there, but I'll go. Yes. Okay. Thank you. I do see it now. I think it clarified the intent with saying it's made with a non-sterile component. I do believe there are going to be some unintended consequences with that. However, there are quite a bit of, there's more obviously testing requirements that pharmacists have to go through, in terms of stability studies, USP 51 testing for any multi-use product. And so if there are other commercially available products that are on the market or come on the market, that would be problematic for the products that you already have studies for. I think that's the first thing. There may not be compatibilities if there are different preservatives that are being used in each of the commercially available products. And then the other thing would be is if one of the products is, or one of the components is a sterile, commercially available sterile product, but the other ones are not, and they're non-sterile, I'm not sure if it really mitigates the risk, because you're going to end up having to sterilize it again. And so I don't think you're really achieving what you want with that if we would have to use one sterile component and then the rest of them would be non-sterile components. It's possible if you, my preference would be to strike the whole thing, but if I do understand the reason for having it, maybe if you say is made where all of the components are available, commercially available in sterile products, because that does make a little bit more sense. If they're all sterile, then maybe you don't need to go to non-sterile components. So that would be my comment. I do think the way that it's written now, it could be potentially very problematic. So thank you very much.
Thank you.
Our next request for comment is from John Gray. And John, you should be able to unmute yourself.
Hi, thanks. Again, good morning again. This is John Gray. I'm a registered pharmacist with Kaiser Permanente. First up, we want to provide some comments on the immediate use requirements in the proposed regulation. We appreciate the clarification that the required documentation associated with immediate use preparations may be present in the medical record. However, we continue to believe that the proposed documentation requirements for immediate use in 1736B will almost certainly interfere with hospital pharmacists' ability to provide timely patient care in emergency situations such as code blues and other urgent or time-critical situations. Specifically, we could not agree more with Rita Shane that a pharmacist who is assisting with medication preparation during a code blue or other urgent situation should not be burdened with ensuring that the documentation of the medications being prepared and administered meet the proposed requirements. More importantly, as others have already said, Section 1.3 of USP 797 provides robust guidance on the preparation of immediate use CSPs. We understand that there is language similar to 1736.1b in current regulation, and we disagree with that provision now in current regulation. We also understand that the board might have information about cases where the practice of immediate use compounding may have been used improperly. However, we are not aware of any empirical evidence to indicate that the approach to immediate use compounding of CSPs in the USP chapter creates a threat to patient safety that would necessitate additional regulation. If the board has any such empirical evidence, then we would respectfully request that they share it with the regulated public. If not, then the board should follow its stated approach of only imposing additional requirements that are necessary for public safety and remove the requirements related to immediate use compounding from the proposed regulations and revert to the requirements in USP 797. Moving on to 1736.1d, prohibitions on compounding. We believe that the changes that were made prior to the meeting have removed our concern about 1736.1d3. Previously, it read as though it could have prohibited the practice that Chair Serpa was describing earlier, where if a Nafcillin pre-made bag is commercially pre-made bag is not available, it could prohibit compounding of Nafcillin using only sterile ingredients, sterile vial, sterile IV bags. So we believe that change has mitigated our concern there. We still do think that some important words might be missing from the proposed 1736.1d4. We assume that the intent is for this requirement to apply to CSPs that for which sterilization is required before use. One example might be using non-sterile components. So we just think that it may be a benefit to add something like when sterilization is required, but cannot be sterilized within the license.
All right, I'm sorry your time is up. Our next request for comment is from Sean. Sean, I'll let you know when you can unmute. All right, Sean, you should be able to unmute yourself.
I'm sorry, I think I already answered, I already spoke.
Okay, thank you very much. All right, then our next request for comment is from Mark Wagner. Mark, you should be able to unmute yourself.
Again, my name is Mark Wagner, and I'm an associate with the law firm Baker & Hostetler out of our Washington, D.C. office. I'd like to comment on the red line on the screen under D2. Because the board expressed an intent to include animal compounding within this proposal, the red line on the screen now includes additional text, quote, unless allowable under AMDUCA. I'd propose adding additional language after that phrase to clearly state or applicable FDA guidance on animal drug compounding so that the aforementioned GFI 256, which will be implemented next week, is incorporated in this regulation. Thank you.
Thank you.
All right, the next request for comment is from Robert Jackson. And Robert, you should be able to unmute. We'll try that one more time.
I think I've already made comment for this section. Thank you.
Okay, thank you. Sorry about that. I have people raising their hand and also typing in the Q&A.
No.
We have Chi Hisu. So Chi, I'll let you know when you can unmute. Chi, you should be able to unmute yourself.
Can you guys hear me?
Yes.
Yeah. Hi, my name is Chi Su. I'm a registered pharmacist at UCSF. My comments regarding 1736.1 Section B, specifically on the documentation, the expanded language on the documentation. Immediate use compounding are frequently needed in emergency department and code situations, and echo other commenters' feedback that proposed language on document really could cause a delay in patient care during these already stressful and high-risk environments, especially when the pharmacists are being called into these code situations. Patients are already coding in the room, and pharmacists are trying their best to incorporate all the situations involved, and having to consider documentation along with those situations would be very challenging and would potentially delay their ability to provide the appropriate medication needed at that moment. Thank you for your time.
Thank you.
All right, this is the moderator just doing one last check. All right, I believe that is the end of comments. Shall I close the Q&A panel?
Please do, thank you.
You're welcome.
Okay, I think I would like to summarize some of the decisions that we made and then open it up for the board members if they had further comment based on public comment. I see that in section C that we're going to change it to patient populations, that we're going to assure that the FAQ addresses some of the concerns in D1A regarding the ASHP or FDA list of drugs of short supply. What we didn't talk about, but I heard in one of the commenters, and I think is a good comment, is D4. If it's appropriate, if the board members agree, is that it say in Supervising Inspector Acosta also, when sterilization is required and cannot be done within the license, look, something to that effect. I think that that was appropriate. Dr. Acosta, what do you think about those increased words?
I kind of feel like it's implied already. It's fine for clarity.
Okay. Let's add it. I think it'll be helpful. But I agree with you. I thought it was implied, but there appears to be some question. Board members, those are the areas that I documented during our discussions and during public comment. Do you have any additional comments or any comments based on what the public has said?
I have a comment.
Go ahead. Can you turn your microphone on?
Can you hear me? Yeah. On 1736.1, subsection B, we heard various stakeholders and practitioners talk about the time it would take and possibly have loss of productivity and could be detriment to patients' health. I was going to suggest to remove the third sentence, which is the last one, or modify the language, or reduce the documentation so that there's enough to keep in medical record, but it does not take as much time. So, I'll defer to subject matter expert to suggest something that could, take care of the issue at hand where it would take a lot of time and it's still safe for the patient.
Before Christine speaks, I just wanted to let you know, as stated, this is current language, but there was one phrase that's added, one section that was added is actually the number of units is not in current language. And that's also something that may not be easily retrievable in the medical record. So that was the one thing. Otherwise, if you're like at a code, you have a code sheet that already has the patient's name and identifier. It already has the date and time. It already has the CSP, and typically the pharmacist is signing the code sheet. So we were trying to incorporate those documents that are already available so that they don't have to create a new separate document. So this is part of the workflow of attending a code. The only thing that was different was the number of units, because sometimes a long code you'd have to make maybe another epi drip for a baby or something like that. Christine, any other comments?
I was going to say basically the same thing. When drafting the law, we were looking at what was already available. And in the practices I've been in, you have a code sheet and you would write down, epi quad, and you would write ×1, then you would cross it out and write ×2. Then you have a patient sticker that has all of that information that goes on the code sheet. So this is already available. So I guess I'm interested in hearing where it becomes burdensome, because it's already tracked. In a code, sometimes it depends on what kind of code you're doing. It has a timeline, and by the time you write when things were administered or when it was compounded, so it's even more specific than what we're asking. I mean, the intent is definitely not to make more work or to take them out of that, but it's to make sure that there is a documentation of what the patient was given, because there are accidents that happen in codes.
So I just wanted to make a comment. I think what sounds like is being discussed really is the difference between what you are required to possibly put on the label when you're handing it off to the code leader versus your documentation when you do your final code documentation at the end of the code. So I think that sounds like, so what you're talking about is you're doing your tally sheet, what doses you're making, what time, how many, but there's also, I think at times if they've gotten really crazy at the code and you're maybe drawing it up, handing it off, writing it down, but you're making something else. So anyway, I mean, in the end, you're writing it down, but I'm thinking that in terms of slowing anything down, if this is like the documentation is not the label that you have to hand off.
Correct. There's no additional requirements for the label on anything that's done in a code. The only labeling requirements would be what the chapter already requires in 7. None of this is required on the label. And also in my experience, if you open a code box or any of those things, at the end, a responsible party takes that open med kit back to the pharmacy and there is a reconciliation of what was used.
Mm-hmm.
And so there's many different forms that these items could be documented in.
Mm-hmm. So maybe an FAQ?
Yeah, this is an area that we will have an FAQ, but because of the comments, I decided to add additional information about where it could be found, because many people don't read the FAQs and they just read this and they get them concerned. But I agree, an FAQ. Members, any other comments on this section before we move on? Okay. Thank you. Moving on to section 1735.2, personnel training and evaluation. I believe the language as presented in the meeting materials is appropriate and consistent with the board's consumer protection mandate. Ensuring appropriate training is vital to patient safety, and the cross-reference to facility standards operating procedures, or SOPs, assures the issue is fully considered in the compounding operations. I would also highlight, as proposed, 1735.2b, the language would allow for the aseptic qualifications from one premises to be used for another premises under specified conditions. I believe this is a big change in the board's current regulation requirement. I'd be very interested in what members of the public think about, what our members on the board and members of the public think about the language. I also like to note that on the displayed slide, I'm recommending some changes in response to public comments received in subsections B, C, and E. Again, thank you to all of you who submitted written comments. I found many of the comments very thoughtful. I know that it's kind of hard for me to continue on the script when you're reading the screen, so I'm going to take a little pause here because I don't want to be doing two things at once. It's probably very difficult. We received comments regarding facility design. The goal of the language is to allow competency from one site to transfer to a second site. However, the language may need further refinement to clarify. Facility design is intended to refer to a design proposal or template, and not an exact architectural drawing to replicate. I'd be interested during the public comment to receive information from stakeholders on how we can make this language more clear. So regarding the facility design, I think we're on the same intent, the board and the public, but it's the wording. Identical, design, those all have different meanings, and so we tried to wordsmith it a little bit to make it more clear that the intent is that similar design or templates could be used across systems or multiple pharmacies, such that you only have one competency at one site and it would transfer to other sites. But they have to be similar enough. We understand they cannot necessarily be exact in how to word that. So I'd be interested in comments from our members and from the public on that. Okay, members, do you have any questions or comments on this section?
So, Maria, I would agree about using the word identical. I just don't think is a good idea. I'm not a wordsmither, so I don't know what would be, but I don't think that's a good idea under a.
So what does it say on the screen now?
There'd be Where are we?
So design
Yeah, the
is
design.
the word, okay, go ahead. I'm sorry, I shouldn't cut you off.
No, just, I don't know if identical would be a good word, because to me, I'm not a lawyer, obviously. I say that all the time, every meeting. But I just don't think that just is gonna cause a lot of
Heartache, yeah.
confusion. So I don't have a suggestion, unfortunately, but I would just like to flag that, in my opinion. I don't think that's a good idea.
I think we discussed this in 825, it was still a challenge. So I do think the word identical is very hard for people to know exactly what's identical, right? Because identical means like a replica. But anyway, I think the word's identical. So for instance, let's just talk about one LSC. So if you have SOPs at one LSC, then you open another one, they essentially most likely will be the same, but you may have some SOPs because one facility is making, does some other types of products or something, so that there are going to be across, like a little Venn diagram, right? Some similar SOPs, but not. So it almost needs to say which SOP. So it seems like it, to relate to number 3, like could be SOPs about, cleaning, or, something kind of specific to what we're really looking for. What do we want them doing in every single place that's identical? So SOPs for, it does have here number 3, the PECs are the same type and sufficiently similar, unless that changed, I don't know, to accommodate the use of the same SOPs describing use and cleaning. So it does have, refers to that. So I don't know what other SOPs, like gowning and garbing, things like that, would be the same. And then as far as facility designs, if it was, probably the 2 distinctions would be clean room suite versus the segregated compounding area. So, but I don't know if that encompasses all, kind of compounding settings, but I'm guessing it kind of does. So, that one is a little hard. So I see Christine shaking her head.
So we're just over here trying to solve the problem. So if we took what we did in 3, which seems to be more what you guys are alike, and it says the facility design are sufficiently similar to accommodate the use of the same SOPs describing I don't like use and cleaning, but something in that, because the intent is, an SCA is extremely different than a clean room suite, but clean room suites are not all equal, right? So do you do HD? Do you not do HD? Do you go into an ante room and then a non-HD to an HD? That's a big garbing and use difference versus the standard that we see is a buffer room, and then there's each side, non-HD and HD, right? So that would be one type of clean room suite, which may be transferable to all the other ones, because garbing and cleaning and all that would be used the same versus some of the other ones.
Mm-hmm.
Yeah. So that's what we're gonna.
So I'd like to make the suggestion, and I guess we don't have an attorney to ask, but we would ask Ann maybe to help us, is if we put that kind of language on the screen now to help with the public comment, so that they can comment on the new change that we're suggesting, like at this moment, rather than have everyone comment about the language we don't like. Does that seem appropriate?
Yeah.
Okay. So on the screen, I think we should change it to similar to what Christine Acosta said. The facilities design are sufficiently similar to accommodate the use of the same SOPs. And at this point, I just see a period there. Members, any comments about that suggested change before we go to public comment?
I agree.
Inspectors, do you have any comments? Okay, and I think Ann shows it on the screen.
Were we going to say, because now it has SOPs are identical, so, I mean.
What, I'm sorry.
Well, so at some point, like now we have 3 things. 1, SOPs are identical, but then 2 and 3 also refer to SOPs. So do we still need number 1? Because we're referring to SOP. I don't know. what
There's other SOPs that are not about the room and not about the PUCs. There's other SOPs, so I would prefer to leave it. I don't think it's duplicative. There's garbing, there's testing, there's competency, there's all these other SOPs.
True.
I see wheels turning, that's why I'm
I
pausing.
know. I still think just the word identical is always going to be problematic.
Okay, that's a good comment. So we'll come back and circle to that. That's a good.
I don't have
okay.
a suggestion.
That's the word. I see. Thank you. Did I miss something before we move on?
No, what I was just going to say is some of this we can probably wordsmith a little bit later as well with council if we want to really focus on like the policy piece of it, make sure that there's an understanding of what's where you all want to go, and then, subsequent to the meeting, we can work with the chair and council to really like refine the language, because there'll probably be additional changes once we work with council a little bit more.
Thank you. Members, any other comments on this section? Okay, seeing none, I think we're ready for public comment. Public comment, we'll start with those in Sacramento. Any public comment for section 2? Come on up. We haven't done, no. This is all brand new.
I'm back, and I still say thank you again. This Part B that we're wordsmithing, I won't belabor it, but I love the concept. I think it's great. Even in community practice, there are times when you have a situation where sterile techs are out, especially if you look back to COVID, right? And if you have a technician who has passed the aseptic manipulation training in a facility that is comparable to your own, you can do some very quick training, make them read your policies and procedures, observe a garbing and gowning. But you've already known that they can do the fingertip touch test, the media fields, and if you're doing comparable, and that's not a very good term, I recognize that, but if you are doing comparable type of compounding, okay, vial and bag compounding, or sterile to sterile compounding, or changing the package size compounding, those sort of things. If all of those things are the same from one facility to the other, and you're using the same type of facility, okay, there are definitely ways that sterile technique, okay, aseptic manipulation can go from one facility to another, where SOPs don't have to be identical. Okay. So I appreciate you working on this. I wish I had better language to offer, and I don't, but I encourage you to continue to work on that process. I also want to thank you for some of the changes. Am I getting ahead of myself? I am, I think. Get my numbers right. 36.2C. You guys haven't really talked about this. Did you want to only talk about B? Or do you want to talk
the
about
whole
the other
section?
change? Okay. So on 36.2C, that one is changing so fast. I'm having a hard time keeping up. I apologize. That one's fine. It's D. No, I'm going to have to collect myself. I apologize. I'll submit my comments in writing. Thank you very much. There's been too many changes on the fly.
I appreciate it. Thank you, Dr. Kottman.
Hi, Melanie Horn on behalf of Sutter Health. I also want to thank the board for the on-the-fly changes to clarify, and also the ability to utilize competency across facilities when they have these similar options. One suggestion to consider, only because this is a new requirement that I've never seen before, but in 1736.2B, it talks about the PEC type and unique identifier, and we had many of our team members not understand this was related to the PEC, so just suggested to add the PEC unique identifier, even though the language appears to state that. It was something new that many had questions on, so just fielding kind of an FAQ there. Also, in regards to the language potential, in USP, the terminology used for facility designs, this is just a suggestion, the facility designs are of the same type of SEC and design. and sufficiently similar. So the terms used, that is the section in USP that discusses the various applications that Dr. Acosta mentioned. So that may be a way to translate directly the language of USP into the intent. One other section that I want to point out would be in regard to 1736.2C, which Dr. Cotterman has mentioned. There is on-the-fly changes. I only want to mention that aseptic manipulation as a part of the quality assurance program still lends to any potential QA failure, and so potentially looking at how we can be very clear with the QA. So one suggestion would be ongoing training and competency specific to identified gaps in procedures and SOPs followed shall occur each time quality assurance programs yield an unacceptable results, as defined in the SOPs referenced, et cetera, of CSB by compounding personnel. So there's a kind of a gap in there for my time. But that's a potential opportunity there. And then under 1736D, the first word used was defined specifically by the Board of Pharmacy. The term applied here is compounding personnel, which would indicate all persons who have any use in the compounding process, which could include all of the roles such as compounder, oversight, et cetera, stocking and cleaning staff, people who check and verify, and this would not apply to aseptic manipulation. So I have two proposed changes to this language. Either change compounding personnel to all persons who compound and keep it aseptic manipulation, or remove and say compounding personnel make roles and say in demonstrated
3 minutes are up.
Prior to resuming. So I can submit those in writing as well.
Thank you. Any other comments in Sacramento? Okay, Tricia, I don't see any here. We're ready for WebEx.
Thank you, Madam Chair. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of the screen, or you may simply raise your hand. It's not necessary to do both, just one or the other. I do see Rita Maria has a request for comment. Rita, you should be able to unmute yourself.
Rita Maria.
Thank you so much for this opportunity. We really appreciate the board opening this up for discussion regarding 1736.2 subsection B and permitting compounding to be performed from one licensed site to another based on certain criteria. You know, the comments that I wanted to provide is it is rare and not common that the physical layout of a clean room or segregated compounding areas are identical. If the intent of the board is to differentiate the type of the room, such as classified versus non-classified, we do recommend removing number 2, so the facility designs are sufficiently similar to accommodate the use of the same SOPs, and update item number 3 to include secondary engineering controls are the same type to meet the intent of number 2. Thank you very much.
Thank you.
The next comment is from Sam Martinez. Sam, you should be able to unmute yourself.
I think this is important. I would also like to reiterate on 1736.2, number 2, I think if the intent is, it sounds like it's really the secondary engineering control unit should be similar. So maybe being more specific, for instance, if it's negative pressure, positive pressure, or so forth, so we know exactly what the intent of the board is. And maybe for the SOPs saying that they're similar in nature surrounding personal training and evaluation or something along those lines. Thank you.
Thank you.
All right, the next request for comment is from John Gray. And John, you should be able to unmute yourself.
Hi, good morning again. John Gray, registered pharmacist with Kaiser Permanente. Thanks for the opportunity to provide comment. We really appreciate the board's efforts to create a pathway for portability of aseptic competency evaluation and training. This has the potential to be very useful for organizations that operate multiple pharmacies that prepare and dispense CSPs. We do respectfully request that the board consider clarifying 2 elements of the proposed regulation. First, it's unclear to us why the unique identifier of a PEC or PECs used to perform validation must be recorded. We would either suggest removing that requirement or, helping the regulated public understand the justification for keeping that in there. Second, although the term premises is ubiquitous in pharmacy law, the term itself is not defined in the pharmacy law and might mean slightly different things for different categories of pharmacy licenses. This could result in variability in how this flexibility is applied, and therefore we respectfully request that the board consider clarifying the proposed regulation to be more clear about the intent of the portability provision. One approach might be to say something like aseptic qualifications from one licensed pharmacy may be used for another licensed pharmacy if all required conditions are met. This could maybe also be addressed in an FAQ if you prefer not to change the regulation itself. And then lastly, I just want to comment on Board Member Barker's comment about the SOPs are identical. I want to echo her concern that if you have two different facilities, one of which performs a different type of compounding, the SOPs of those two facilities may not be completely identical, but the SOPs material to an individual working safely in both of those facilities' clean rooms may be identical. So for example, one facility, say a home infusion pharmacy, has an automated TPN compounder, so they have a separate SOP that addresses how to use that device, whereas facility 2 doesn't have that device, so doesn't have an SOP. But that's really immaterial. If you have someone going from facility 1 with the compounder to facility 2 without the compounder, the existence of that TPN compounder and its SOP may be immaterial to that individual's work at the second facility. So we would respectfully request the board continue to workshop that element around the SOPs being identical. Thank you very much for the opportunity to provide comment.
Thank you.
All right. The next request for comment is from Rick Rhodes. And Rick, you should be able to unmute yourself.
Yes, thank you so much. And thank you for incorporating many of the comments that we've all put in to this. I would like to discuss subsection D in regards to when a compounder or a pharmacist fails any aspect of the aseptic manipulation evaluation or the media fill. My concern on this would be in particular for pharmacies that have 1 or 2 pharmacists on staff. And I do understand the importance of ensuring that the pharmacist at times, even if they're not compounding, that they are able to pass an aseptic manipulation competency so they know what they're actually supervising. My concern would be if they fail any aspect of that. With the new 797, media fills now include a surface sample and a touch or a fingertip sample at the end. So if they were to recover, 2 or 3 CFUs on their fingertip, then that media fill would be failed and they would have to redo that. The soonest that the results would come back for that competency would be 2 weeks. So I'm not sure what would happen in that situation with the pharmacists that would have oversight, especially for the pharmacies that only have 1 or 2 pharmacists on staff. So my recommendation would be to have some leeway where if a pharmacist, overseeing does fail it, either they would have a certain amount of time to be able, to retake it, or they would have to have some pending result. But I think that flexibility would be helpful for people that are trying to comply with this. And, it may lend itself to people actually designing poor media fills in order to just guarantee that their pharmacist passes it so they don't get pulled off of oversight of that clean room. So that would be my comment for that. Thank you.
Thank you.
All right, I see no further requests for comment. Shall I close the Q&A panel?
Please do. Thank you.
You're welcome.
Thank you, everyone, for your comments. As you heard, we're probably going to have some additional changes before the board meeting on Section B, primarily working on SOPs are identical. I also heard about including maybe the abbreviation SCC in the facilities SCC design, so we'll talk about that also. Reading that the facility design could be misinterpreted as being the whole building when we're only really talking about the compounding areas, and so that's a potential to improve also. Members, any other comments you wanted to make based on public comment?
Actually, I do have another comment, which I had previously, but I forgot. I have a lot of them. So this is about D, which did get mentioned a few times, so I'll probably reiterate some of what was said, but this is what I had already. Well, so in looking at this, so that point that it says compounding personnel, first I would just want to address the list of those that are discussed as performing media fill. So in the USP, that's section 2.3, they have in table 2 and 3 that it's required for media fills are required. And when I say media fills, I mean glove fingertip testing and the subsequent surface sampling and all the other competencies. But it lists the compounder, the designated person or persons, which is not in this, and then personnel with direct oversight of compounding personnel. So, but when you look at this is compounding personnel, which in the definition, as was pointed out, it's all persons involved. So that includes verifying CSPs. But in the USP, it does not designate that that person is required. It's per facility SOP. Also, I find that so if we're going to name each person who has to repeat a media fill, if they fail it, then the designated persons need to be added. Also, I would remove handling CSPs, which is really a whole different function. I mean, after a CSP is made in a clean room and it's taken out of the clean room to be delivered to a patient, that person is handling CSPs. And that's actually the wording in section 19 for CSP handling, storage, packaging, shipping. So I would not include the word handling. I also would agree that as far as a pharmacist who is not a compounder, that if they fail the hands-on manipulation of a media fill, that it seems very stringent that they cannot provide oversight. So oversight, being checking, I mean, they're not doing it they're not compounding. So because it can take up to 14 days to pass that, and again, I think it was pointed out in these smaller hospitals, it's not going to be a lot of people who can step up to do that, and I don't think it creates any type of patient safety issue as long as that person is not compounding. So I'm just concerned about the oversight. I would agree that a compounder who fails should not compound until they pass. Mm-hmm. That one I would agree with. So just kind of pointing out a few things there.
Yeah, there's some interesting points. I agree with the handling. I really wanted to see what the inspectors also say about that. But also note, it does not say this is about media fill. It just says competency. So whatever your role's competencies are, those are the competencies. And so it's not just everyone has to pass media fill. So if that's not part of your job description, then that's not a competency that would be looking at. The definitions of compounding personnel, I think we probably could work on that offline to kind of make sure that we have the right people. And I probably want to hear a little bit more, and maybe we have, I don't know how to do this discussion about, because I feel strongly that the person with the direct oversight should have a current competency. Otherwise, 6 months, 2 years, they're still not competent and they're still providing oversight. So I think there's probably a happy medium in there where maybe it's not all the time, but it's, within X number of days or something like that. I think there's probably some discussion we can have there. I see Supervising Inspector Acosta.
What would you think about adding in another section that says, unless the oversight person has pending results? You know what I mean? Something to the effect of, we can give you a 2-week window as long as they have already retested and we're pending results on whatever they have failed. Because, I would agree, if they're not physically doing it, but at the same time, if you couldn't pass your aseptic technique, how are you going to properly oversee a technician to do it correctly if you couldn't do it correctly? So there's that a technician's not allowed to have independent judgment, so we have to have somebody that's overseeing them, but we will have a problem with it, with the overseeing pharmacist. So something to the effect, oh, there we go. Go, Ann, go.
I think we need, instead of pending results, because you can have pending results, I could retest every month for the next year and still be pending. So I think we should have a time, something like that. But again, this is something that we're not going to, since we're not going to go back to public comment on this, right? We will work on something and then provide language for the board meeting where we'll be going through all of this all over again. I hope you all attend the board meeting also. Members, any other comments in this section? I think we have some really excellent comments and still work to do on this complex issue. Is everyone ready for lunch? Let's take a break for lunch. We'll come back at 1:15, so it'll be about 45 minutes. We are not even halfway through, but I know we have an exciting afternoon coming in. So I'll see you at 1:15.